Okay, good afternoon again. So I changed the light so you can see the screen better, but try not to fall asleep, okay? So, great. So today you will have a lot of me. So the next 3 lectures will be mine. So we'll talk about pneumonia, then we'll talk about shock, and we'll talk about non-invasive positive pressure ventilation. Then we will end with the test. Okay, so great. So let's talk about pneumonia. So this year I removed one part of the pneumonia that I gave in the previous couple of years, which is what? No, HCAP, I didn't give it since 2016. Last 2 years, what happened? COVID. So I removed the COVID part of the pneumonia. Thanks God that COVID is much lower now. So I will concentrate on community-acquired pneumonia with the 2019 guidelines, and I will concentrate on the half-VAP pneumonia guidelines in 2016. So this is what we will talk about in our lecture today. So again, I have no disclosures. So we need to recognize what type of pneumonia when we manage the patient. Is he community acquired? Is he HAP or VAP? If it is community acquired, we need to know where to treat him. Will we send him home? Will we admit to the floor? Will we admit to the ICU? Take the mask off so you can see me. Okay, so when we treat him at home, treat him on the floor, treat him on the ICU. Sometimes when you are on the floor, you think this patient needs to be on the ICU. And when you are on the ICU, you think the patient needs to be on the floor. So we have some criteria to tell you what to do and where to treat the patient based on some guidelines criteria. Also, what antibiotics you need to pick for different types. If you will treat at home, if you will treat on the floor, if you will treat in the ICU, antibiotic regimen for community acquired pneumonia is different. Treatment for HAP and VAP are not the same. So people think hospital acquired pneumonia and ventilator associated pneumonia, the treatment is the same. They are not. And we will show you that based on the guidelines. Great. So I will just do interaction, will not do it through the phone. So we'll start with the first case. I will read the case first. So 39-year-old, previously healthy, came to the ED in January. Paid attention to the red words. Okay. I mean every word I mentioned in every case that I will discuss today. So every word has some meaning. So January with 5 days history of upper respiratory symptoms, dry cough, malaise, myalgia, and subjective fever. 1 day later, she noticed dark color of the urine, right upper quadrant vein, and had diarrhea and vomiting. Sneezing noted during interview in the emergency department, and husband noticed confusion for the last 2 days. She smokes pack a day times 10 years, so 10 pack year history, no recent travel, no pets, no occupational exposure, lived with her husband, no risk for HIV, no known drug allergy. On exam, she's confused, respiratory rate 18. Every word in red means something, so pay attention to that because we will go through some questions and you need to pay attention to that. Confused, respiratory rate 18, statin 98% on 2 liters, blood pressure 106/72, febrile 103.2, tachycardic 136. Chest examination, right anterior and posterior bronchial breath sound and crackles. Abdomen, soft, mild right upper quadrant, tenderness, skin slightly jaundiced. Rest of exam is normal. Everybody brought his stethoscope today? Yeah. So number 1, bronchial breath sound means pneumonia, right? So bronchial breath sound means pneumonia. What's the normal breath sound? Vesicular, not cleared auscultation bilaterally like what I write in my notes even. So vesicular. What are the vesicles? Alveoli, right? So vesicular breath sound are the alveoli. Make sense? Great. So how do you describe the vesicular breath sound and the bronchial breath sound in the textbook? Anybody read textbooks for examination?
There's a gap.
Gap, okay. Gap in which one? Which one? In the bronchial or the vesicular?
Bronchial.
Bronchial. Okay, so gap between inspiration and expiration. What else? Duration of what?
Inspiration, long.
Okay, inspiration and expiration
Equal.
equal in bronchial breath sound. Which is longer in vesicular?
Inspiration.
I hear expiration, I hear inspiration. Which is longer?
Inspiration.
Listen to your heart, listen to your lungs. Take a deep breath. You have the vesicular, so inspiration is longer. So inspiration is longer. So what they described in the textbook, vesicular breath sound, inspiration is longer than expiration with no gap. Bronchial breath sound, inspiration is equal to expiration with a gap in between and has a hollow character as if you are blowing in an empty glass bottle. When you go home, get a glass bottle, whatever the type, drink what's inside it, make it empty or throw it away if you want, put it beside your mouth, blow on it. You'll hear the hollow character of the bronchial breath sound. Now everybody knows how to differentiate between vesicular and bronchial breath sound. Everybody is shaking head, yes, I don't believe you. All what I said means nothing. What will mean something for you? Get your stethoscope into your ears. When you listen to the lung, I want you to ask the patient to open the mouth a little bit and breathe from his mouth. Why is that? Because when they breathe from the nose, if they have some congestion, which is very common with lung infections, you will hear a lot of noises from the nose, okay? So let him take a breath from the mouth, little bit, deep breath in and out. So put your stethoscope in your ears, put it in your lung, and breathe in and out. I assume all of you are here today. I didn't hear anybody sneezing or coughing or so I assume you have normal lungs. So you have the vesicular breath sound. Learn this vesicular breath sound that you hear in yourself. Make sense? You learned it? Okay, remember that for the next few seconds. Now I want you to move your stethoscope. Keep it in your ears, but move the stethoscope itself to your trachea. Take the same breath sound. Does it look different? This is the bronchial breath sound. Move your stethoscope between the trachea and the lung to know the difference between the bronchial breath sound that you hear in on the trachea and the vesicular breath sound that you hear on your lung. Get two breaths here, and learn it. Different? Yes, this is different. So why is that? All the breath sound in everybody is from airflow in the bronchial system. Normal lung, pneumonia, COPD, anybody has breath sounds, they are developed in the bronchial airway. What happens when you have normal lung? These vesicles will modify this bronchial breath sound. So when you hear it in your chest, you will hear the modified breath sound, modified bronchial breath sound by the vesicles. That's why we call it vesicular breath sound. Make sense? When you develop pneumonia, these vesicles are consolidated. So they conduct the bronchial breath sound as it is to your chest wall without modification. So you hear the bronchial breath sound without modification. So you hear bronchial breath sound in pneumonia. Got it? This is the first thing I want you to know about physical exam in pneumonia. So when I ask you what are the specific physical findings when you examine patient with pneumonia, bronchial breath sound is number one. And when we say specific, you don't hear them in something else. So don't tell me crackles, don't tell me fever, right? So these are things can happen in different things. What else other than the bronchial breath sound you hear only in pneumonia? Egophony. What else? Whispering picturiloquy. What's whispering picturiloquy? You don't know. So let's tell what whispering. I'll tell you what's whispering picturiloquy. What else? So bronchial breath sound, egophony, whispering picturiloquy, resonance, increased vocal resonance. You hear that with the stethoscope. Last one, you can feel it with your hand. Increased tactile vocal phragmitis. These are the 5 specific physical findings of pneumonia. We'll learn them on you today. Okay, so we learned the bronchial breath sound. Let's put your stethoscope in your ears, put it in your lung, and whisper 99. Then move it to your trachea and whisper the same whisper 99. See how louder you hear it on your trachea compared to the lung. This is what we call whispering pictoroliquid. In the patient, if he has unilateral pneumonia, you can compare one lung to the other. So if you suspect bronchial breath sound on one lung, listen to them, let him whisper 99 on his suspected pneumonia lung, let him whisper on the other lung, and you will see how louder on the pneumonia lung. Okay, what else, Fuad, you said? You said what else we can hear? Increase vocal resonance, right? So put your stethoscope in your ears. Put your stethoscope in your chest. Say loud, 99. No, don't say loud. Say it loud. But you say not only 99, but say it loud. Then move it to your trachea and say the same loudness, 99. See how louder you hear it on the trachea compared to the lung. This is the increased vocal resonance. Some people forgot to bring the stethoscope today, or everybody brought the stethoscope. Even if you don't have your stethoscope, put your hand on your chest, say loud, 99. Put it in your trachea, say the same 99 as loud as it is. See how much you feel it. You can feel with your hand or with the side of your hand, any bone, to feel the vibration of the 99. This is the increased tactile vocal parameters. Make sense? Now we will know what's bronchial breath sound. We'll know what's whispering pictoroliquid, what's increased vocal resonance, what's egophony, what's the tactile vocal parameters. Make sense? Great. Now we are done with this stethoscope. Let's put it up. Great. So let me give you some labs. So CBC, white cell count is 11.7. This is very important, the bands, 46%. When I was on pulmonary last rotation, I think a couple of weeks ago, I had a patient and I asked for 2 blood cultures. Patient had white cell count of 5,000, no fever. And I asked for 2 blood cultures, and my fellow and my resident told me, why you are asking for blood cultures? And I told him, okay, what in his labs made me ask for the blood cultures? Was bandemia. Patient had 15% band. Anything above 10%. Very few things can cause bandemia. Infection, what else? When you treat patient with bone marrow suppression after chemo with bone marrow stimulant. So these are the 2 main. Steroid doesn't cause it. Steroid causes leukocytosis by demargination of the white cell count, not from stimulating the bone marrow to produce immature white cell count, white cells. Okay, we talked about leukocytosis in DKA, and 3 years ago this was raised, and I looked it up when we were Dr. Whitey was giving the lecture. What can cause leukocytosis in DKA? What do you think?
Stress response.
Stress response. Yeah, hemoconcentration. These people are very dehydrated. Opposite to the leukocytosis that you see that hemoglobin is 12. Patient is severely dry. He will become anemic later on. So his baseline, he has anemia. So the third thing is same like the steroid demargination of the cells, which is probably related to the stress that the patient is at. So bandemia is very important to look at in immunocompromised people. HIV, somebody on immunosuppressive medication, all the collagen diseases. So very important. Patient comes confused. You don't have any reason. The only thing that tells you patient has infection is the bandemia. White cell count is normal, no fever. Who else may have infection without fever? Immunocompromised, DKA, adrenal insufficiency, okay, renal failure, liver cirrhosis. So these are people, you may have infection without fever or leukocytosis. So you need to be cautious about that, okay? I'll not go through what are the people, some infections, they may have relative also bradycardia to the fever. This is something to look at later on. So patient had 46% bands and platelet count is 90,000. Pay attention to the 90,000, okay? Sodium 125, creatinine 1.1, BUN 21, bicarb 19, anion gap 16, bilirubin 2.2, direct 1.1, indirect 1.1. AST is elevated 96, ALT 62, CK somewhat elevated 15, 13, and lactic acid is 4.2. Okay, so What can give you some pneumonia with low sodium and diarrhea? Sometimes jaundice. Think about Legionella. So this is in the board. If you see that combination, they are looking for Legionella. So think about that. Okay, X-ray shows. What else you see in the X-ray? So I'm giving you only 2 arrows, right? So pneumonia on the right lower part where you hear the bronchial breath sound, and what else? What's the lower arrow showed? So probably effusion. You don't see the costophrenic end. Fuad, why did you say multilobar pneumonia? There is. So this is multilobar pneumonia. Why is different? Remember, the multilobar is different from single lobe pneumonia. We'll get to that. Okay. These are all points to tell you the severity of the pneumonia. So all these are factors. All the red things that you saw will tell you how severe your pneumonia is. Great. So I will ask you 16 questions. Anybody knows why I'm asking 16 questions? Yeah, so the community acquired pneumonia 2019 guidelines, they had 19 questions and they answered. That's why I'll ask you these 16 questions and you tell me your answer. Then we will see what the guidelines say. Okay, yes or no? Raise your hand if yes. Don't raise your hand if no, but please raise your hand if you want to say yes. I don't want everybody to say no. So interact. Nothing is wrong. Will you send sputum, gram stain, and culture for this patient? A lot of yes, maybe 1 or 2 no. Okay. Will you send 2 blood cultures for this patient? Nearly everybody is yes. Okay, great. Will you send urine strep antigen and Legionella antigen for this patient? Looks like a lot of yes. Will you send influenza test? Then now with the COVID, will you send COVID test? Looks like everybody wants to send influenza and COVID. Why influenza? January, right? So you see, the January was meant, right? And she was sneezing, and when you saw her in the ED. Now we also send COVID. Will you use procalcitonin to help you decide for starting antibiotics? No. So anybody? So the question is clear. Will you use it to decide to start antibiotic? No. So everybody say no, or you are tired from raising your hand. So, but I expect everybody would say no. Okay. The patient is in the ED. Where will you manage? Outpatient, floor, ICU. Who would like to send this patient home with some antibiotics? No one. Who would like to admit to the floor? 3, 4, okay, 5. Who would like to admit to the ICU? Majority want to admit to the ICU. So we have some splitting, maybe more for ICU, less for floor. We'll talk about that. Okay. This is the question that will determine. Did you decide between outpatient and inpatient management based on clinical judgment only, clinical judgment and CURB 65, clinical judgment and pneumonia severity index? Who decided for A, based on A? Who decided for B? Calculate 1, calculate the CURB 65, okay. Who decided for C? A lot decided for C. Yes. You had a chance to calculate the PSI. That's great. So, but yes, okay, we'll get to that. Okay. You memorize the PSI. You don't have to memorize it. It's like available everywhere. So there is some pneumonia app too. You can download. Okay. Question number 7. To decide between ICU and floor. This is where we had the conflict between 2 groups. To decide between the floor versus the ICU management. You used clinical judgment only or clinical judgment plus ITSA ATS 2007 severity criteria. Everybody, yeah. Wonderful group, very quick calculation. So, okay, so B, okay. No one used A? Okay. Question 8 and 9 and 11. 8 and 9 and 11. Based on your site of management, I want you to use your pen and the paper in front of you. Write your antibiotic that you will treat well. So we had no outpatient, we had floor, and we had ICU. If you decided for ICU, write what antibiotic you will treat with. If you decided floor, write what antibiotic you will treat well, because they are not the same. Okay. So we skipped question number 10. Let's get to question number 10. If you suspect aspiration, would you add anaerobic coverage? No?
Unless he has abscess.
Okay. So anybody would like to cover for anaerobes in this patient? No one? Anybody is neutral, yes or no? No? There are some neutral. Okay, that's okay. So we'll see what the guidelines say. Okay, because all these questions they answer. Okay, question 12. Would you add steroid? Yes or no? No? Okay. Question 13. If the patient tests positive for influenza, remember the symptoms were 5 days ago, would you treat influenza?
Yes.
Yes, no? Okay, so we have split between yes and no. No, no, because the symptoms is more than
3 days.
3 days. Okay.
They're hospitalized.
Hospitalized. How if it is outpatient? Would you treat influenza?
First day, 48 hours.
48 hours. We'll see what the guidelines says. Okay. So we have some room for improvement based on the guidelines. You will be surprised. Okay. Inpatient, outpatient. Okay. So we'll see the guidelines, what it's saying. It looks like we have some controversy for this question, question number 13. If the patient tests positive for influenza, would your initial management include antibiotics for this patient? We are talking about this patient.
Yes.
Yes. Okay. So you will. Okay. So when you treat influenza, you treat. Okay. Initially. Okay.
Initially, do we get influenza positive?
No, you already have influenza positive.
So
We talked about treating the influenza, but would you treat this patient with antibiotic in addition to the treatment of influenza if you decided to treat for influenza?
yes.
No?
Yes, yes, yes.
So we have a lot of yes, few of no. We'll see what the guideline says. Because all these questions, they answer. So but just I wanted you to stimulate your brain. So when we get to the things, I don't want to show you what they said. Just think about what you decided and then compare that to the guidelines. If the patient improves, anybody read the papers I sent? Because all these papers I sent, right? So I know your time is tight, but I sent you these papers, so read them, okay? So I didn't send it with no reason, because this is something to help you to prepare yourself. You need to read all the papers I sent. They are very important. I sent also, somebody asked me for the acid-base lecture. I sent it, you got it? And I tried to send you the ACLS recording from the skills lab yesterday, but Bree couldn't open the zip folder. So I have it on my Jump Drive. I can give it to Bree to send it to you. Then we will start downloading the Zoom recording and we'll load it to the website also. Okay. Question 15. What is the appropriate antibiotic duration? Option A, 7 days if no complications like abscess, empyema, necrotizing pneumonia. Option B, 14 days if MRSA pneumonia with no complications. Option C, less than 5 days if the patient is clinically improving quickly. Who would like to go with A? Most of the people. Who would like to go with B? MRSA pneumonia treatment duration is 10 days at least. 10, 15 days with no complication. How about Pseudomonas? 2 weeks. You'll be surprised what did the guidelines say. MRSA pneumonia 7 to 8 days, like any other pneumonia. Pseudomonas we used to treat for 14 days. Sometimes I do that, but the guidelines says 2016 guidelines for HABVAP 7 days, even for Pseudomonas. Okay. The only thing they said about Pseudomonas, if you are double covering Pseudomonas for VAP and patient is in shock and cultures came back sensitive to both antibiotics, patient still on pressure, don't stop both antibiotics. Don't stop one of the two. Continue the two until your patient is not in shock. Okay? Because they can develop resistance quickly. Your patient in shock, requiring pressure, is very sick. If you stop one, develops resistance to the other, he may die. So this is another thing in addition to changing the 14 days to 7 days, they said patient on shock. If the patient improves, should you follow chest imaging after discharge to look for underlying malignancy?
No.
No? Yes? Okay. So we'll see what the guidelines say. Okay. So this is the community-acquired pneumonia 2019 guidelines. Make sense? So let me start with a couple of things. They have recommend and suggest. Recommend this strong evidence. So you need to follow. Suggest, you can take it, you can leave it, okay? Some weaker evidence. So when we say recommend versus suggest, recommend, strong recommendation, strong evidence, suggest, weak recommendation, you can think about. Make sense? Great. So they have these 16 questions, but remember, these guidelines are for people who are not coming from any other country or living in another country. This is for pneumonia, community-acquired pneumonia for people in the US did not recently travel. This is not guideline for patients who are immunocompromised, okay? And they mentioned that in their thing. So if you have immunocompromised person comes with community-acquired pneumonia, antibiotic may differ, okay? They are mainly covering the common causes for pneumonia, strep pneumo, Haemophilus influenza. So, and they are also talking Mycoplasma, Legionella, all these organisms that commonly cause pneumonia. And also they are talking about covering some MRSA and Pseudomonas. They consider all other gram negatives will be probably the same coverage as Pseudomonas. Definitely you have some difference in resistance, but this is what they are covering. Consider all other gram negatives will be covered with the same antibiotic that you cover for Pseudomonas. This is the ETSA ATS 2007 pneumonia severity index that you calculated very quickly to decide this patient needs ICU. So you have major criteria and minor criteria. Major criteria are easy on the bottom. If you have any of the major criteria, your patient has severe pneumonia. Definitely if somebody in septic shock, on pressors, or respiratory failure requiring ventilator, they will be severe pneumonia, right? Unless they are intubated for something else, come with stroke or something like that. But anybody who needs ventilator or needs pressors from pneumonia, they are severe. Any one of the major, you are severe. You need 3 of the minor criteria, okay? 3 of the minor criteria. Think about the curve 65, but we'll remove the 65, the curve. They have this criteria. What's missing in curve 65 that does not make curve 65 the best to tell you? Multilobar pneumonia like this patient with hypoxemia with PF ratio 250 or less. This is not in curve 65, right? And also your patient with severe pneumonia and some vitals and labs that tell you this patient has severe pneumonia, like hypothermia, low platelet. Okay, so these are things that you are not. Leukopenia, what's the count? Leukopenia is worse than leukocytosis infection, right? Hypothermia is worse than fever and infection. When you treat these people with infection with antibiotics, they are immunocompromised. You will find your patient starts to have leukocytosis, then starts to have fever. He was normal thermic and normal white cell count. When you treat them, they are getting leukocytosis and they are getting fever. Are they worse? They are better because their toxin suppression of their bone marrow. Fever is responsive from our body to infection. Fever is not good for the bacteria, okay? So bacteria will proliferate more in lower temperature. Fever will decrease the proliferation of toxin suppressing the bone marrow. When you start to kill the bacteria with the antibiotic, bone marrow will start to work, release bands, leukocytosis. So this is important. So these are the criteria, and let's see what our recommendations one by one. Okay, question number 1. In adults with community-acquired pneumonia, should gram stain and culture of the lower respiratory system, so should you send sputum culture for these people or not? They split it into 3 groups. Outpatient, they recommend no. All of you said, or some of you said no, and some said yes. So outpatient recommendation, not suggestion. Recommendation, no. Inpatient, they recommend to send it if you have severe pneumonia, if your patient has MRSA or Pseudomonas in the past, or if your patient you are treating to cover MRSA or Pseudomonas, you need to start that. Or if your patient got IV, not oral, antibiotic in the last 90 days, this is what the HCAP that was to be part of the HCAP. So now it is part of the pneumonia with high risk for MDR. Make sense? IV antibiotics, not oral, parenteral, i.e. IV, antibiotic in the last 90 days is risk for MDR, for VAP, for HAP, for Pseudomonas, for MRSA. Okay, make sense? So if your patient is not severe, you can send cultures. I usually send cultures. Anybody who requires admission to the hospital, I like to send 2 blood cultures. But they recommend only for these 4 categories. IV antibiotics last 90 days, severe pneumonia, you are starting covering for MRSA or Pseudomonas, or history of MRSA Pseudomonas infection anywhere, and more likely if it is in the lung. Okay, so these are the things. 2 blood cultures. Again, the same. They say we recommend not to send 2 blood cultures for outpatient. They suggest not routinely do blood cultures for floor, but it is suggestion. I still send 2 blood cultures for the floor. Okay. They recommend to send 2 blood cultures. Same recommendation to send the sputum. Severe pneumonia based on ATS ETSA guidelines. Patient you are covering for MRSA or Pseudomonas. Patient had a history of MRSA or Pseudomonas. Patient who got IV antibiotic in the last 90 days. Make sense? Got question 1, 2, 3? Not 3 yet. Okay. So in adults with community acquired, should Legionella and strep antigen be sent? They will tell you also for strep antigen, suggest not to send routinely, except if your patient has severe pneumonia. Okay. I usually send it because this is suggestion, not recommendation. Because sometimes the only thing that comes back positive is the strep antigen, which will be something good to tell you that your patient has some infection, strep pneumo. And you can send the strep antigen in the urine up to 3 days after you start antibiotic. So if you forget to busy night, and you forget to order the strep antigen in the morning, you gave him antibiotic yesterday, in the morning you can still send it. Up to 72 hours can still be possible. The bad thing about the urine strep antigen that it does not tell you about sensitivity, right? So you will need to consider, is it sensitive to that antibiotic or not? So different from any culture, you can run sensitivity on it. So strep antigen, they suggest no unless you have severe. I still do it because it's suggestion. Legionella, same thing. They suggest or they recommend to send you Legionella if you have some pandemic. There was, you heard about the first Legionella was in hotel with the air conditioning. You will see me, you go to grocery stores, right? All of you. You see this sparkling water for the vegetables and things like that. This can transmit Legionella too. So when this thing starts, I run away. Not from the water, from the Legionella. So anyway. So they suggest not routinely to send urine Legionella, except if you have some pandemic or community has some Legionella, also if you have severe pneumonia. So severe pneumonia, you have to send urine strep antigen and so simply anybody in the PCU or in the ICU send urine strep antigen and Legionella antigen. You can also send on the BL Legionella antigen. Okay, so Legionella PCR. So on the floor, it's up to you because it's suggestion not to do. Question 4, in adults with community acquired, should respiratory sample be tested for influenza virus at the time of diagnosis? So should everybody get influenza antigen? So again, if you are in the season of influenza or if you clinically suspect influenza, send it. Same thing for COVID. So now we screen everybody for COVID, but this may go down later on, I hope, if we don't have any surges again. So in adults with community acquired pneumonia, should procalcitonin plus clinical judgment be used? And the answer is only clinical judgment to start your antibiotic. Don't use procalcitonin, may take 6 hours and longer up to 24 hours to go up. So if your patient comes early, it is negative. So if you will check procalcitonin, it will help you to de-escalate later on, and you need to check it 48 hours after you check the first one. I see many patients get the first procalcitonin negative, nobody checks it later on. Okay, so you need to repeat it because maybe your patient came in the window when it's not high yet. Clinical prediction rule out plus clinical judgment versus clinical judgment alone to be used to determine inpatient versus outpatient. So for treatment location, so everybody said we'll use the PSI. So they recommend to use the pneumonia severity index rather than the curve 65 to decide if your patient will be admitted to the hospital or not. So it's also available on UpToDate, available in apps, so you can look at that and calculate it. Show the clinical prediction rule out prognosis plus clinical judgment versus, so simply do you use the pneumonia, maybe sure that this is the correction, inpatient, general, medical, so floor or ICU, do you use clinical judgment only or use the pneumonia severity index? Again, you should use the SITS 2007, and they used it in 2019. So this is valid and it's good. We will do 0 changes. Question 8, in outpatient setting, which antibiotic are recommended for empiric treatment for community acquired pneumonia in adults? I will split the outpatient because they love that in the board. I'll split the outpatient pneumonia that you decided to treat them as outpatient to two groups. First group, you know very well. Who's that? You. Second group is not you. Who's you? Healthy, young adult, no comorbidities, I hope not alcoholic. This is you, right? No risk for MDR. So this is you. So somebody healthy like you on the board, treatment is different from some elderly person with comorbidities, alcoholic, risk of MDR. So these people are treated different. These people who are not you will be treated very close to treatment of pneumonia on the floor to make it easy for you to remember. So you, what antibiotic you will get or you will treat yourself with if you get pneumonia and you decided not to come to the hospital? Amoxicillin, doxy, quinolones will take that quinolones away. Azithromycin, so macrolides. Okay, so quinolone is for the other group. Okay, so let's see here. So they tell you here, you, no comorbidities or risk factors for MRSA or Pseudomonas, no risk for MDR, no comorbidities, amoxicillin, doxycycline, macrolides. Then, if you have comorbidities, you see here the quinolone monotherapy is in this group. And you see here they combine two antibiotics. This is exactly how you treat pneumonia on the floor, right? Either quinolone alone or a mix of some macrolide or doxy and beta-lactam, right? So, but here for outpatient, you need to pick beta-lactam that can be given orally. You see stronger recommendation for amoxicillin. So in the board, if they give you amoxicillin or doxycycline or macrolide and give you quinolone, don't pick the quinolone for yourself. Got it? So you and not you. Great. Healthy person like you, I will not go through the doses of antibiotic, but the outpatient azithromycin, 500 and 250s. All inpatient azithromycin 500 every day. Floor ICU 500 every day. I would recommend also ceftriaxone. They tell you 1 to 2 grams. I recommend to use 2 grams in the hospital. Ceftriaxone 2 grams a day. Okay.
How much is this for the outpatient?
500 the first dose. Like the Z-Pack that you use, and 250 second, third, fourth day. Make sense? I see like in the apps you have the 500 for 3 days if you will treat, but this is for outpatient. You will treat with the 500 every day, 3 days, because it stays long. For inpatient, based on this guideline, everybody should be treated minimum how many days? Oh, 5. So antibiotic minimum 5 days for even if they get better. This was one of the questions, and we'll get to the answer to that. Okay, so here on the right side, there's the dose of the antibiotics. Inpatient setting. So now we will start to see how did you treat. So some of you said on the floor, some of you said on the ICU. So let's see. I'll not ask you what you treated well, but look at your treatment and see if it matches. If you decided floor, then see if your antibiotic goes with the floor treatment or not. So I have this table to tell you severe versus non-severe. On the top here is non-severe, and on the bottom here is severe. They are same for these two columns. They are different in these three columns. So again, as we said here, on the floor or non-severe, because your non-severe may be also in the PCU or so, but you calculate the pneumonia severity index, you decided his non-severe pneumonia, you can treat with quinolone alone or combination of beta-lactam plus macrolide or doxycycline. When do you use doxycycline rather than macrolide and quinolone? QT interval. So if you decide to treat with quinolone or azithromycin, get a baseline EKG to be sure. I usually, if it's getting closer to 500, I would try to avoid quinolone and macrolide. So if you are in the ICU or you have severe pneumonia, let's say the proper word, severe pneumonia, never treat with one antibiotic. So if you have any option for severe pneumonia with one antibiotic, this is wrong. You have to have two. So beta-lactam, the most common, we use ceftriaxone or ionisine, plus either macrolide or quinolone. If your patient has significantly prolonged QT, I would replace those with doxycycline. Make sense? So you have to treat with two antibiotics in the ICU. Floor can be one antibiotic if you pick quinolone, or two antibiotics if you decide for beta-lactam plus macrolide or dox. Make sense? This is the first difference. Here, they will tell you if you have prior respiratory isolation of MRSA, if you have respiratory isolation of Pseudomonas, here you add MRSA coverage, then get cultures. Here you can observe. Here you can observe if you had history of Pseudomonas and the non-severe. If you have severe with history of Pseudomonas, we need to cover Pseudomonas. Here, if they had any high risk for MDR, like IV antibiotic in the last 90 days, you have to treat in severe and non-severe for the Pseudomonas or the MRSA. Make sense? Okay. So non-severe, ceftriaxone, as I told you, 1 to 2 grams. I want you to cover with 2 grams. Azithromycin, 500 daily. Okay, not 500 and 250s for the inpatient. There is little bit stronger or better quality data for the beta-lactam plus macrolide compared to the quinolone, but there are some areas that have some macrolide resistance, so it may not be the best for that case. Suspected aspiration pneumonia, should you cover with cover for anaerobe? What antibiotics cover for anaerobe? Ionisine, clindamycin, Zosyn, metronidazole, Augmentin, Ionisine, the Phenom, meropenem. So they suggest not to cover for anaerobes for patients with aspiration pneumonia, community acquired within aspiration. Okay, so this is adult with community acquired pneumonia risk factors for MRSA or Pseudomonas be treated for with extended spectrum. So this is what we answered in this question. So we recommend to use if you have severe. In patient settings, should adult with community acquired pneumonia be treated with corticosteroid? And they also, for severe, they suggest no. For non-severe, they recommend no steroid. There is family medicine guidelines that recommend steroids for severe pneumonia. So different from this guidelines. But here they recommend not to use for severe, non-severe, and they suggest not to use steroid. Unless you have shock or COPD exacerbation associated, you can use your steroid. Community acquired pneumonia who test positive for influenza should be treated. Let me tell you one important thing. What's the lecture? Name. Pneumonia, right? So we are talking about influenza pneumonia, not influenza upper respiratory symptoms. Influenza pneumonia, outpatient, inpatient, regardless of the duration, treat. Pneumonia means you have physical findings of pneumonia and you have X-ray that shows infiltrate. Influenza pneumonia, regardless of the duration, treat, please. Recommend influenza in inpatient to be treated. Suggest influenza pneumonia outpatient to be treated. Make sense? We're not talking about influenza runny, clear chest X-ray. This is different. This is when we look at exposure. But this guideline is for influenza pneumonia. This policy for influenza, should we cover with antibiotics? Yes, because they said viral infection is commonly associated with bacterial infection. No guidelines for the COVID. I use the same guidelines of influenza when I was talking about the COVID. So I covered with antibiotics early when we had no data about the COVID in March 2020. So I used to cover with antibiotic until we rule it out and go from there. Outpatient and inpatient adults with community-acquired pneumonia who are improving quickly. What's the shortest duration for antibiotic? Minimum 5 days. Don't stop antibiotics before 5 days. Make sense? Last question. Would you follow imaging? No or no? No? Good answer. So they suggest, but it's also suggest. You can take it or you can leave it. They suggest not to follow X-ray for pneumonia if the patient improved quickly. If the patient doesn't improve, then you have to follow. And actually, when we follow X-ray for pneumonia in the hospital, we follow for improvement, correct? Incorrect. We follow for worsening, right? Is getting worse? Infiltrate will take 3 to 4 weeks, up to 6 to 8 weeks in elderly. So infiltrate will not go away when you are in the hospital, but you may develop effusion, you may develop abscess, you may develop something. This is for patient who is not responding to your treatment. So, and their rationale is you want to look for underlying malignancy. They tell you any patient with risk of underlying malignancy, you should do the screening CT, right? So he will qualify. Most of the patients that you follow and you found malignancy, underlying malignancy for this pneumonia, they qualify for screening imaging every year. Make sense? So other people, healthy, young, improve quickly, no need to repeat, but it's up to you because it's suggestion. These are the comparison between 2019 and 2007 guidelines. Everybody's familiar with curve 65. I used to initially get confused which is 20, which is 30. The UN is 20, respiratory rate is 30, or the opposite. So numbers go up. So 20, 30, 90 to make it easy for you to remember. Okay. What's 65? Age. Okay. So the 65, when you decide to use the curve 65, we said better to use the pneumonia severity end. But if you decide to use that 0 or 1, you treat outpatient. What's the 1? Only the 1 if it is the age. But any other 1 from the curve, you admit. Make sense? If you have 3 or 4 or 5, probably you need ICU. The modified is CRB 65. This is something to use in your clinic. What's the only lab in all the curve 65 is the U, right? So you can use a CRB and decrease 1 from the curve 65. So if you have any 1, admit. So your patient in the clinic, you want to the lab is 4 p.m., admit or send home. CRB 65 is 1, admit. This is the pneumonia severity index questionnaire that you did very quickly. And our patient scored 99. Class 1 and 2, up to like 70 points there. These are less sick people, very low mortality, less than 1%. You can treat them as outpatient. The others admit, and 4 and 5, you need probably ICU. So our patient scored here class 4. There is another severity index SCAP, so severe community acquired pneumonia. So they are using major and minor criteria that are very close to the pneumonia severity index. They modified the curve 65 a little bit. I don't want to bother you more, but if you have 10 points, your patient is very sick. And this is something to use to admit to ICU or to the floor because we have controversy. But I would prefer to use the pneumonia severity index rather than that. So they added few things to the curve 65, like altered mental status and multi-lobar pneumonia and the oxygenation less than 250 PF ratio, in addition to the curve 65 in the minor criteria. And they changed the age to 80. So if you have 10 points, every minor criteria is between 5 and 10. So if you have 2 minor criteria, you will qualify for 10. If you have any of the major criteria, any one of them is more than 10. So 10 points is what tells you it is severe pneumonia. Anybody heard about SMART Cup? So also it's abbreviation for all these things. Every letter is abbreviation of something. If you score 3, high risk for intubation. Another way to look for. Then the best is what we talked about, the ETSA, and we have our patient had 4 of the minor. We needed 3 to say this is severe. So our patient had 4, so I probably would admit this patient to the ICU. Make sense? Don't forget Legionella, because treatment of Legionella, macrolide, quinolone, doxycycline, period. These are the antibiotics that cover Legionella. So if you don't cover and your patient has Legionella, they will not do well. Make sense? Influenza, I probably would like to add a COVID, because these are things that require specific treatment. MRSA, bioterrorism, what would you worry about in bioterrorism? What organism? Anthrax, right? Common question on the board. What do you see in the X-ray of anthrax pneumonia? Wide mediastinum because of hemorrhage, mediastinal hemorrhage. So you see wide mediastinum with pneumonia in the board. Think about anthrax. They don't tell you bioterrorism. They tell you somebody is working in something related to animals, wool sorter factory, or somebody who, like a vet works on a farm, or somebody has a farm and deals with things, especially after abortion, things like that. Second part is HAP and VAP. HAP and VAP. HAP, hospital-acquired pneumonia definition, pneumonia that develops 2 days after. This was in the pre-test questions, right? 2 days after admission. But you don't get risk for MDR till day 5. So on day 5, if you start to develop pneumonia in admission, cover MRSA and Pseudomonas, okay? Day 5. They think day 3 or something like that, maybe he came with the organism and started to show or something like that. But risk of MDR can be, but also clinical judgment. So MDR risk on day 5. VAP, 2 days on ventilator. Pneumonia that develops after 2 days on ventilator. You remember the VAE that we talked about yesterday? So VAP, you start with VAC, then IVAC, then probable VAC. VAC, ventilator-associated condition, hypoxemia requiring 3 of P price or 20% FI2. Then infection-related VAC, you have some infection that's causing the VAC. Then you look for any evidence of infection, virulent, sputum, cultures positive, things like that. Positive organisms for all the HAP and VAP is usually think about MDR, MRSA, and Pseudomonas and other gram-negative organisms. Okay, this was one of the pre-test questions that you had yesterday. VAP, risk for MRSA. You remember the 5 things? One, I modified. Instead of IV antibiotic, I put it oral antibiotic to have something to select from the 5, right? And I thought it was a negative question, but I wanted to know the 5 things. So anybody had previous IV, not oral, antibiotic in the previous 90 days, somebody who has ARDS, somebody who is requiring renal replacement therapy, dialysis or CRRT, somebody in septic shock, somebody 5 days in the hospital or more. Make sense? These are the 5 things for risk for VAP, MRSA. Risk for HAP and risk for Pseudomonas, only one thing, IV antibiotic in the previous 90 days. All these other items below, IV antibiotic in the previous 90 days, IV. To prevent VAP, you said the most cost effective is? Here in our hospital or our ET tubes have continuous suction. So this is another channel beside the tube that you connect to suction either continuous or intermittent, are okay. Mainly your cough around the ET tube, secretion will accumulate above the cuff from the oropharynx, because your cuff is not 100% sealing your trachea. This secretion will go to the lung, cause the pneumonia. So somebody thought, why should I leave the secretion above the cuff? So they created the ET tube with very small channel that has a hole above the cuff, and you connect that to suction. So any secretion accumulate there, you suction it so it doesn't go to the lung to cause pneumonia. Make sense? This is continuous or intermittent subglottic suction, reduce that. But the most cost-effective costs $0, because this tube is more expensive than the other tubes. So $0, 30 to 45 degrees. Okay, very quick. That was a pre-test question, and some were tricked in this question. VAP, cover MRSA if they have risk for MRSA, and double cover Pseudomonas. All the VAP, double cover Pseudomonas. Some people pick cover MRSA and Pseudomonas. You have to cover MRSA and double cover Pseudomonas. Don't combine two beta-lactams. Why? What's that? Yeah, what's the mechanism of resistance for beta-lactam? Beta-lactamase. So if your bacteria is producing beta-lactamase, all beta-lactams are done. Cefepime, zosyn, meropenem, all are beta-lactam circle, right, or cycle. So don't combine cefepime with. There are any situations you can cover with two beta-lactams? Yes, there are. Yeah, meningitis, encephalitis, one of them is something like that. So okay, so you can cover two with two beta-lactams. Okay. Linezolid and vancomycin. But remember, linezolid is bacteriostatic. So if you have bacteremia with MRSA, we don't prefer to use linezolid. Okay, so linezolid, if you have bacteremia, is not preferred. Here for the HAP. If you have risk for MRSA, cover MRSA. If you have risk for Pseudomonas, you cover with one or two, or one or two, one or two. Both are correct, but based on your patient, they say something strange. If your patient is at high risk of death, double cover. If your patient is not at high risk of death, single cover. Or if your patient got some IV antibiotic in the previous 90 days, double cover. Make sense? So this is how you decide. Okay, you see these two circles. So this one, no risk of mortality, and risk of mortality, somebody is requiring pressors or so, something like that, severely ill, that then you double cover for Pseudomonas. Or if he got IV antibiotics in the last 90 days, you double cover Pseudomonas, because they are higher risk for MDR. Duration?
There are Pseudomonas dispense sensitive sometimes.
What's that?
There is Pseudomonas sometimes isolated dispense sensitive.
We are talking about the empiric treatment before you get any cultures.
Okay.
So you are starting treatment and you have nothing to decide based on other than your clinical judgment and the guideline.
Okay.
Not after you get the sensitivity. The only time when you get the sensitivity, you continue to Pseudomonas coverage if your patient is on pressors. Make sense? Don't let PharmD push you to de-escalate quickly. Never de-escalate your antibiotic. Culture is negative. It was just sent 9 p.m. yesterday, so it's less than 24 hours. So it's not 2 days. It is 48 hours to 72 hours after your cultures are negative de-escalate. Why 48? Because if the culture is sent the day before yesterday, 11 p.m., don't count the day before yesterday. Don't de-escalate today, unless you will come and de-escalate at 11 p.m. Make sense? 48, I wrote it clear in a circle, 48 to 72 hours, you decide to de-escalate. Duration, 7 to 8 days. I think this was 2003 or 4, very good study that looked at duration and 7 to 8 days, including MRSA with no complications. If you have the empyema, if you have abscess, if you have necrotizing pneumonia, it's 4 to 6 weeks antibiotic, right? Pseudomonas, controversy, many of the pulmonologists don't like to cover Pseudomonas less than 14 days. ID would push for 7 days. The guidelines say 7 days for Pseudomonas. Make sense? But minimum These are the risk factors to have anaerobic, severe bad teeth. Don't forget for pneumonia to look at the teeth. Odontalist patient does not have anaerobic in his mouth. What do we have in our throat? Yeah, so strep groups, right? Strep viridans, strep other groups of strep. We don't have anaerobes in our oropharynx unless the bad teeth, sometimes more common in elderly, alcoholics, or if you smell foul smelling, if you have abscess or empyema. So you may need to consider covering for anaerobes. These are the antibiotics that you mentioned that covers your anaerobe. Good paper for aspiration pneumonia in New England, I think 2019, review article in New England about aspiration pneumonia. I would like you to look at this article and read it. Take-home messages. Management of pneumonia depends mainly on what type of pneumonia you are dealing with, where will you treat your patient, home, floor, ICU, severity of pneumonia if you admit them. You need to send the appropriate labs. You need to start empiric antibiotic appropriately. Any questions about the pneumonia? Did you answer the 16 questions that we discussed for the community acquired pneumonia? Tap and back. No HCAP, right? So 2016 guidelines said there is nothing called HCAP. We didn't know what to do till 2019, till the community acquired pneumonia came, and they put the HCAP as part of the community acquired pneumonia with MDRs. Make sense? Yes.
For emergency pneumonia, do we have to use any precaution, droplet precaution, airborne?
Yes, MRSA you have to do droplet pneumonia. They sometimes put the patient with MRSA, screen positive. I forgot to tell you, if you start empiric antibiotic with to cover MRSA, you have to send nose swab. Okay, so for MRSA, because this may help you to de-escalate. Okay, if you started empirically. If your patient already have MRSA, then you don't need to send them. We have blood culture showing MRSA. We have fecal culture showing MRSA. Why should I send this one? Well, even the swab came back negative. Will you stop the MRSA? No. But if you start empiric treatment, be sure you send the MRSA so you can de-escalate.
Contact precautions and
A contact, only contact for MRSA. This was your question, like droplet? No, no droplet. For your board, this is a question on the board. Anything I tell you, it may come on the board, you will see it on the board. You will remember me and the board in good way if you remember the answer. In bad way, it's a bad teacher he mentioned, but I didn't. So you need to know what's the difference between airborne isolation and droplet isolation. What organisms you isolate for airborne? That's not just TB. Okay, so you need to know what are the organisms that you need to isolate. Airborne isolation means like N95 mask. Okay, airborne. So flu, you wear just regular mask, but airborne infection, all the airborne infection, you need to wear the N95. Make sense? Great. Would you like to continue? We'll give you a 5-minute break, either before the non-invasive or before your test. So you prepare before the test. We'll see. Okay. Both? Okay. Okay, so let's talk about shock. Okay, shock. I like standing and doing something. So this is a 5-second break. So stand up and do some activity so you can refresh yourself. Although also you can walk and pick one of these papers if you didn't get it that has questions. Yes. You don't want them to stretch? That's okay.
They are super interesting.
Okay.
Yeah.
You can get some snack, get something, and return to your seat.
There are some numbers looking for.
Anybody, anyone is slow answering questions in boards? You are? So you are like me. In my USMLE, I left 20 questions in every session. Because it's like 1 minute per question. I can't finish. They are very slow. But in medicine boards, it's two minutes per question. For all my other 4 boards, it was 2 minutes per question. But I finished maximum 10-15 minutes before the time in every session. So if you are, some of us are slow answering questions. So let's start so we can give you more than the 30 minutes for the questions if we can. So, okay, have a seat and we'll start talking about the shock. Everybody had the paper with the differential diagnosis. So this will be our, we have 2 cases. This will be your exercise. If you want to do it, everyone by himself or every 2 or 3 sitting together can just do this homework together. I will get to that for every case. We will start with that. Again, I have no disclosures. Objectives, we need to know what's the definition of the shock. There is some new change in the definition, came back from the sepsis 3 in 2016. We'll talk about that. And this is different from what we used to use before 2016, the sepsis 2. And this is little bit not accepted in Europe. So this is for us here in the US. You will see some people or some papers coming from Europe talk about severe sepsis. We don't have severe sepsis anymore. We either have sepsis or septic shock, right? There is nothing called severe sepsis since 2016. No, not everybody, even here in the US, believe in that. Even here, they send me queries. Was the patient sepsis or severe sepsis or septic shock? And I tell them sepsis or septic shock, there is no severe sepsis, right? So, but I still get that. Anyway, so then we will talk about through the cases how to manage different, before we manage how to create a differential diagnosis for our shock. And I will tell you why this is very important. And then how to manage the type of shock that we have. Management, I want everybody to be, when I was year 6, I had a question. We had essay questions in my university. So the question was management of DKA. And I went out of the exam, I will get 100% of this question. I answered it like what it is in the book exactly. Then I got 1/3 of the mark. Why is that? Management includes differential diagnosis, investigations, and treatment, right? And I wrote only treatment. So we'll talk about management. So if you have management, it's not just treatment. One important thing when I join you in the cases that you have or in professor rounds, I see people are talking about differential diagnosis, but nobody is managing severely ill patients. So we talk about 30 minutes about differential diagnosis for the patient, but nobody wanted to start managing this patient. So you need to think about severely ill, manage when you are sending labs, okay? especially in shock, because what's the best management in shock?
Flowets and pressors.
What's the best management in shock? One word. Early. Early flows. We'll take it. Early, early, early. This is what makes difference in shock, any type of shock. Early management, right? Don't write in the board early. Okay, so early management is very important in shock, because if the patient is in sepsis, he may go to septic shock if you don't manage early, right? What's the mortality for sepsis? Give me a percentage. 30, give me a lower percentage. 20, give me a lower percentage. Excellent, good answer, 10%. Okay, what's the management? What is the mortality in septic shock? 40%. 40%. So if you don't manage your patient, he moves from sepsis to septic shock very quickly. You lost 3 of 10 of your patients with sepsis. Instead of losing 1 of 10, you lose 4 of 10. Make sense? Great. And we'll talk about that in more details. So shock is not hypotension. Okay, everybody knows that. Shock is not hypotension. It is organ dysfunction from decreased perfusion to the tissues, causing hypoxemia, causing hypoxia to the tissue. Make sense? And you will be surprised what's causing shock? Infection, right? What's causing septic shock? Infection?
Toxins. Toxin leaks.
Toxins from the organism. Our body. So our response to the infection is what causes the shock. This is in the census 2016. Okay, I'm not sure that in a second. So, Fuad, you reviewed the papers I sent? Anybody looked at last year website? Yeah. So I'll try to modify once we get the new pages. We'll modify those, and also we may put it for you to on share or something like SharePoint or something like that. So you can have it available for all you. Zoom recording, I don't know if they decrease it, it's 45 days and goes away. So we try to download the videos and save it to be available for you till next year until we get the new course. Okay, so these are the types of shock. What's in red? Combined. So you may have combined. That's why it's important. Patient is febrile, septic shock. Don't forget other types of shock, because you may have somebody's coming with diarrhea. He has hypovolemic and septic. Somebody with septic shock and has Takasubu, has cardiogenic in addition to septic. So you may have somebody with septic shock, severe stress, bleeding. So you may have more than one type of shock. One is very obvious. You remember the gray light, the gray color slide in the acid base 2 days ago? So don't rush. Something is very obvious. Don't forget the others. Okay. So everybody knows hypovolemic. Hypovolemic can be hemorrhagic or non-hemorrhagic. Cardiogenic shock, extracardiac obstructive shock like PE, tamponade, tension pneumothorax. Distributive shock, the most common is septic shock. The other one that you may see in the ED, distributive shock other than septic, is anaphylactic shock, right? Then the most important, don't forget the combined. You may have 2 or more types of shock in the same patient, right? We'll talk about these definitions. Actually, I added one. Sepsis, everybody is familiar with sepsis. Septic shock, SIRS. SIRS stands for what? I was giving lecture overseas, and I was saying SIRS and SOFA, QSOFA, and what are you talking about? So SIRS is?
Systemic inflammatory response.
Okay, SOFA. Okay, assessment. And QSOFA, quick SOFA. Okay, then NEWS2. Anybody heard about NEWS2? No? Anybody heard about MUSE2? No? Never heard about them? Because they are in the October 2021 sepsis campaign. They mentioned to don't use QSOFA, and use the SIRS, the SOFA, and the NEWS and the MUSE. And I'll show you that. I probably wouldn't use the NEWS and MUSE because they are very difficult to calculate. So, but I just wanted you, as they mentioned, you know what it is. So the MUSE is a modified MUSE. Okay. So They like abbreviation. But anyway, so this is what I'm telling you, 2016 sepsis-free census. They said, you see here the first column there, sepsis is defined as life-threatening organ dysfunction caused by dysregulated host response to infection. So our response to infection, dysregulated response. So this is what's causing the sepsis. Make sense? How do you define sepsis? 2 in the SOFA. SOFA 2 or higher is sepsis. In the appropriate situation, because you may have somebody with PE and his PF ratio is 100, he will qualify for more than 2 in the SOFA. Make sense? Great. So mortality is 10%. That's what I was telling you. If you go to septic shock, clinically, how do you define septic shock? You give the patient the appropriate amount of fluids, and you have 1 of 2 lactic acid more than 2 or MAP less than 65. This is septic shock. So patient with sepsis, you resuscitated with enough amount of fluid, he still has MAP less than 65, he is in septic shock. His lactic acid is still above 2, you are in septic shock. And mortality is 40%. 40. Make sense? This is the SEP2, I think 2021 also. SEP2 compared the new definition in 2016 to the old definition, and they found from every 5 people that you diagnose with sepsis before, they don't qualify for sepsis based on the new definition. So 20% of people who were diagnosed with sepsis and septic shock, so they didn't qualify, or septic shock specifically. They didn't qualify for septic shock based on the new consensus 2016. Everybody's familiar with the SIRS. A reminder, if you have 2 of these 4, remember here, the bands more than 10% is 1 of the 4. So leukocytosis, sometimes you see in some books 11,000 rather than 12,000, less than 4, leukopenia qualifies as 1 point, or more than 10%, 11% bands qualifies as one of the points. Heart rate 90, not 100, okay? And then respiratory rate more than 20, or if you have hyperventilation and you wash your carbon dioxide and the ABG less than 32. Then temperature higher than 100.4 or less than 96.8 or the 36 degrees. Any 2 of the 4 qualifies for SIRS. This is the QSOFA. 3 things you need to. You see SIRS, you need to. QSOFA, you need to. SOFA, you need to. Okay? To make it easy for you. So the QSOFA, 3 things. Alter mental status, respiratory rate 22 or higher, systolic blood pressure 100 or less. If you have 2 of the 3, this is QSOFA. If you calculate your QSOFA and it is 0 or 1, you don't have sepsis, right? No. You need to calculate the full SOFA. Okay? Because if you're suspecting sepsis and your QSOFA doesn't support you, look for the SOFA. Don't remember the SOFA? Just you need to calculate. Okay? There are tons of calculate. This is the news tool. So National Early Warning Score 2. I assume there was 1. I didn't look at that. But it is simply your 5 vital signs plus alter mental status. The news tool, 5 vital signs plus alter mental. So 6 points. You see that? Your 5 vital signs plus the alter mental stats. This is more used in Europe, but they also used it during the COVID to decide how quickly you need to react. You need to move patient ICU managed quickly. Patient can be managed, outpatient can be managed as floor PCU. So this is the full SOFA. 6 organs. For the brain, they look at Glasgow score. And they give them score from 0 to 4. So 1 organ can qualify for the 2 points that you look for in the SOFA. So for the lung, they look at PF ratio. As I told you, PE was PF ratio 100. So less than 100, he would get 2 points. Where is the PF ratio? PF ratio. So less than 300 would get 2 points. So is he sepsis? Cannot be sepsis. So it should be in the appropriate situation. MAP for the heart, bilirubin for the liver, creatinine and urine output for the kidney, and platelet for the blood. These are the things you look at. What if you have a patient with known elevated bilirubin? he has liver cirrhosis, and his bilirubin is at his baseline, you shouldn't count that in the SOFA. If you have a patient with history of cirrhosis, but you are not sure, count the bilirubin as part of the SOFA. Just give him the doubt benefit and treat him as such. This is how to calculate the NEWS2 and low versus low medium versus high. This is how quickly you need to respond, and this is what was the benefit of the NEWS2. And this morning I found there's something called NEWS2. It was modified NEWS2. Everybody is modifying the previous research and looking at more things. Okay, so this is the 2016 recommendations. Usually they come, sepsis campaign, they come every 4 years. So we had 2008. This is when I started looking at that. First one was 2008. I don't know if there is anything before 2008. Then 2012, then 2016. In 2016, the next one was supposed to be 2020. They wanted to do some changes, so they had some brief modification, 5 modifications, what they called it sepsis campaign 2018. Then 2020, what we had? COVID. So they didn't do the 2020 sepsis campaign, they did the guidelines. This is mainly the sepsis campaign is from the Society of Critical Care. And actually, KU is one of the big centers that created the sepsis campaign, one of the major centers. It's like multi-center thing. And so 2018, they had some modification of 2016. Then it came in October 2021, and I want you to read at least the tables. You will have everything I wanted you to look at, but read at least the tables, and the things that are not in the table, I added to the table. So let's start with our first case. I'll read the case, then I will give you 2 minutes to fill the left side of the paper you have. Okay, so I'll read the case and I will leave it in front of you for 2 minutes. 57-year-old man, previously healthy, presented to the ED with shortness of breath, productive cough, yellow sputum, fever for 2 days, maximum 102, was seen by primary care physician, was given oral amoxicillin. He traveled by car to Las Vegas and came back recently. Ex-smoker, 40 pack year, quit 3 months ago. In the ED, he was confused, hypoxemic, statin 81% on room air, and placed on oxygen 40%, stat improved to 90%, blood pressure 120/40, pulse 130, respiratory rate 30, temperature 101.9. He weighs 100 kilogram, chest bilateral crackles, more on the right side, anterior and posterior, and remember that, bronchial breath sound. No GVD, no edema, warm extremities, tachycardic, but no gallop. Full code. 2 minutes. What I want you to look at this and tell me from this scenario. Anybody saw my sticky notes? You see my sticky notes? How do I develop those sticky notes? I look at your HMP, admission HMP. Okay, I may be wrong. Don't correct your HMP based on my sticky notes. So, because you already saw the patient. I come 4 o'clock, 3 o'clock in the morning. This is my usual time when I come to the hospital, and this is my best thinking. I'm a lot. I sleep 8, 9 o'clock, wake up 3 o'clock, and come to the hospital. So anyway, so this is my best time to think. So this is sticky note. I read your HMP and create my problems, and look at the labs and create the problems. Okay. So modify. Look at the X-ray and modify the problem. Look at the CT and modify the problem. So this is what I do. Why I do that? Because I need to manage every problem. Make sense? Then I add the chronic problem. Patient has diabetes, patient has hypertension, patient has whatever. So the chronic problem. But for the ICU, I look at the acute problems, less than first, then I add the chronic problems at the end. Anybody knows what's the last 3 numbers in my sticky note? Height. Yeah, height in centimeters. Because anybody on ventilator or non-invasive, I need to know the height so I can check if your initial vent settings are correct or we need to modify them. So this is my sticky note. So create your sticky note here. So look at this, my issue. So we'll reverse the job. So I give you the history and physical, and you give me the sticky note. So if you want to work every desk together, every 2 together, create. Then we will start with the people who will give me less problems. You will tell me what problems you have, then we'll escalate. Okay, start. And I'm not talking about fever. I'm talking about diseases. Okay. Really? The lecture?
Oh. Yeah.
And when you tell me a problem, tell me how did you get it from this HMP? One minute. Anybody needs more time? We are okay? Okay. Who got 0 problems? So we can move to the second case. Who has 1 problem? Who has 2? Who has 3? 3? Okay. So let's start with the 3. What are the problems you have?
Pneumonia,
Pneumonia, okay.
hypoxemia,
Hypoxemia,
and
altered mental stats. Okay. So tell me, how did you get pneumonia?
patient is feverish with chest infection, she has productive cough,
Fever, cough, yellow sputum. So the only thing that confirms that you have you can have fever, you can have cough and phlegm with bronchitis, right? So your physical exam, the bronchial breath sound confirms that you have pneumonia. Anything else give you bronchial breath sound? No. So pneumonia. Agreed. So second problem is hypoxemia. Okay. Can you give me better word? Hypoxia. No, we said it's not hypoxia, it is hypoxemia. Hypoxia is the worst word. So, acute hypoxemic respiratory failure. What's the difference between? He didn't listen to you. After repeating gets married, he will learn how to listen. Okay. His first year, he will learn to listen. Anyway, so hypoxemia, we said hypoxia is the tissue hypoxia. What can tell you about tissue hypoxia? Lactic acid, right? So, but what you get with the pulse oximetry and the ABG is hypoxemia. Hypoxemia, if I check our oxygen saturation, we said we are the normal people, right? We don't have pneumonia, I hope we don't have COVID. So if I check our pulse, what will be our pulse oximetry? SAT will be, yeah, close to 100, 98, 99. Hypoxemia is resting pulse oximetry or oxygen saturation less than 95. That's why you remember when they started with the COVID, 94 qualified for remdesivir, you remember? So 95% is the lowest at rest. So I see a lot in your professor rounds or in your cases that you are presenting in the resident report. Patient is setting 91%. He's okay. He's not okay. 91%. He's hypoxemic, right? Patient setting 98% in the hospital all the time. And you look at his vitals, he is 94%. He's hypoxemic. 3% reduction of your oxygen saturation. This is when you need to assess your patient in the hospital for hypoxemia. Regardless what's his original SAT, 3% reduction. I would like you to look at BTS, British Thoracic Society 2017 hypoxemia guideline. We'll give you I give you the didactic every year. I'm not sure if this coming year, this year we did PFT, right? Next year is either ventilator or hypoxemia. These are the three didactics that I do every 3 years. So we rotate. So PFT, hypoxemia, and hypoxemic respiratory failure, and the ventilator. So when we talk about that, I will show you the BTS guidelines. They tell you need to go and clinically assess your patient when they have 3% drop of their SAT in the hospital. Don't wait. Nurses call you when the SAT is below 90%, right? When you have COPD patient in the clinic and you walk him and the nurse tell you, oh, he did well in the 6-minute walk. His original SAT was 95% and he dropped to 90%. He's okay because the guidelines of the Medicare and Medicaid say we will start oxygen if he's 88 or less. But he's not okay. 3% reduction of oxygen saturation with exertion is hypoxemia. You got the hypoxemia? Any SAT at rest less than 95, any SAT with walking dropped 3% from baseline, any SAT dropped 3% in the hospital from baseline. This is hypoxemia. What's hypoxemic respiratory failure? You said acute hypoxemic respiratory failure and he didn't listen. Can you tell me why did you say acute hypoxemic respiratory failure? So this is the acute because he doesn't have history. But why he is hypoxemic respiratory failure? What's the definition of hypoxemic respiratory failure? If your SAT is below how much on room air? If your ABG PO2 is less than how much on room air?
65.
You said on the ABG 55 and you said 65. Can you give me a number in the middle, please? Excellent. So PO2 at rest less than 60 is hypoxemic respiratory failure. Okay, how about the SAT? Less than how much? 92? No, 90, less than 95, we said is hypoxemia. So should be lower to be hypoxemic respiratory failure. 90, excellent. So 90%. So SAT less than 90%. So really anybody you put him on oxygen in the hospital, he's hypoxemic respiratory failure. What is
the ABG to say that SAT is a 90 or we can take
how do you get the SAT?
saturation from the ABG?
No, just use it.
That's why I didn't say it.
Oh, okay.
But we should have ABG.
Okay, so he's 81% on room air. Do you think his ABG will be good if he's setting 81%?
No,
You think his PO2 will be more than 60? The only number that correlates with the SAT is 90% and 60. This is the best number that correlates. If your patient setting 90%, his PO2 and the ABG will be around 60. there any patient you can think about setting 81% and ABG will be okay? No? No? Yes.
COPD.
Not COPD. Yes. Methemoglobinemia, right? So the opposite for the cousin, carbon monoxide. You will have low PO2 in the ABG and 100% SAD because carboxyhemoglobin will be read as oxyhemoglobin with the regular pulse oximetry. How to differentiate between the carbon monoxide poisoning and the methemoglobin? What should you order? ABG with co-oximetry. Co-oximetry has 4 wavelength. The oxyhemoglobin, carboxyhemoglobin, methemoglobin, so you can tell the difference, right? Which disease your goal oxygen saturation is 100%? We'll talk about that in the didactic. Carbon monoxide poison. Which disease you don't start oxygen unless they are below 85%? I will leave it for the hypoxia didactic if you remember the question, because I give you $5 price or something like that. So, and there are Katie Wicked got answered the question because she was on a rotation and they talked about that. What rotation? I will not tell you. She was on a subspecialty rotation and they discussed that the day before I gave them the hypoxemia side. Anyway, what's that? Who's she? She is one of the staff. Caitlin Witt. Yeah, Whitler. I'm actually, I was doing that didactic virtual, and I had the $5 with me, and I wrote something on it, and I just gave it to her 2 weeks ago. So this was in 2020 with the COVID. But anyway, so okay, so encephalopathy or altered mental status, acute hypoxemic respiratory failure, and pneumonia.
So
you want to add something else?
No, I have a question.
I have a question.
So a 3% reduction with exertion is hypoxemia, right? So if someone is having, like, let's say
100% and he goes to 97%, he's hypoxemic.
even okay. That was
I answered. I couldn't give you higher number. He's starting 101%. Who answered 11 of 10? I think. Sabir, you answered 11 of 10 and the acid base, right?
Yeah.
Yes, you are the one. So 102%, and he drops to 99%. He's hypoxemic. Make sense? Great. Who has another problem more than the 3? Okay. Okay, let's start. Yeah. Sepsis. Guys, what's the lecture? I expected this to be number 1. You're telling me sepsis. I'm giving lecture about. She didn't tell you that. This is sometimes. So sepsis. Why do you think sepsis? SIRS qualifies? Yes. So everything qualifies for sepsis. Does he qualify for septic shock yet?
No.
Not yet. Okay. Sepsis. Somebody wanted to add something more. White pulse pressure. What can cause white pulse pressure? Number 1. Number 1. Sepsis, the lecture. Right. Number 2. Aortic regurg. And had a patient we used to teach in Cairo University on standardized patients, and this patient had blood pressure 90/0. And he was walking, helping. So we used to admit him just for teaching. So he was helping other sick patients. He brings them water, he brings them the food. The patient not able to eat. So he was helping other people, and he was very happy that he's staying in the hospital. I think maybe he had homeless situation or so. He was happy staying in the hospital. He gets money from the teaching and things like that, and then he helps other people. And so his pulse, his blood pressure was 100/0, right? So sepsis, aortic regurg, what else? Anemia, hyperthyroidism, any shunting, so intracardiac shunting or lung shunting, or people with AV fistula for dialysis, but any shunting can cause that. What else?
Myocardial failure.
Like pyrotoxicosis, very good. What else? Somebody said something. Pregnancy, right? What else? One organ of the 6 organs of the sofa. Liver disease. Okay. So One disease affects the bone. Disease affects the bone, starts with Paget. Paget disease, excellent. These are all the causes of white Paget. And actually, I want you to pay attention to the drop in diastolic blood pressure for your patient. You see your patient 120 over 80. All the last 3 days, this morning, his blood pressure is 120 over 40. Look for sepsis. This will be the earliest manifestation that happens before drop of blood pressure. And actually, I talked to the KU staff who is part of this sepsis campaign. I told them, have you ever looked at diastolic blood pressure? It's never in the criteria for, no criteria of sepsis at all looked at drop in diastolic blood pressure. And I think this is something very, drop in diastolic blood pressure will explain why we use the MAP rather than the systolic blood pressure, right? So because your patient may have blood pressure, let me give you an easy example to look at. 90 over 30. What will be his MAP? 90 over 30 MAP is 50, right? Diastolic plus 1/3 of the pulse pressure. Pulse pressure is 60. 30 plus 20, 50. His systolic is 90, but his MAP is 50. MAP, what perfuses all your organs, including the brain, not the systolic blood pressure, right? So that's why we use the MAP. This will translate to two things that I love to use one of them. If you work with me in the ICU in the last 5 days that I'm working in the ICU, and you tell me we have admission for sepsis, and I will go and assess the patient, or patient came with shock. First thing I will do, patient is in shock on norepinephrine. In his feet, I will feel his feet. Warm feet, this is sepsis, period. Cold feet, then you think about the other three etiologies. Feet in between, think about sepsis plus something else, the convention. This will also reflect what we used to use. You'll see it in every shock, in any literature that you read, this table that tell you the pulmonary artery catheter or Swan-Ganz. So what will be the only thing that's in sepsis, not in the others? Systemic vascular resistance will be low in sepsis, high on all others. Make sense? So low diastolic blood pressure in this patient will tell you your patient is septic too. It's not in any criteria that we looked at, but that's why I told you every word or number I meant to put it there to pay attention for. So 120 over 40, what's the pulse pressure? 80, and somebody coming with pneumonia, he is septic, right? Great. So anybody wanted to add something else? Coccidio, why did you think about that? Las Vegas. Anything you would like to add from Las Vegas? PE, possible PE, because he drove to Las Vegas and came back. So long driving can put him at risk of PE. What's that? Okay. 1.5. Okay. You calculated what's the score? Okay. So we'll get to that. That's why we said probable PE. Great. What else? COVID. Okay. This was before the COVID. COVID definitely now is always in differential. Anybody who's come with lung infection. What else? COPD. So what's his chance to have COPD? What's the number? We did bets yesterday, so less than 50%. So he may have COPD. What else other than COPD? He is high risk for, or he qualifies for screening CT, right? Because he qualifies for that. Everybody is aware that they reduced the criteria, right? So he qualifies. I wrote this case based on the old criteria. That's why you have the numbers qualifies for the old criteria, but this he qualifies for that. Anything else? What's that?
Lung abscess.
Why do you think lung abscess? Can you get that with pneumonia? Yes, you may need some imaging, so you can have some complications, lung abscess or emphysema. So great. So let's see. Anybody would like to add anything extra? Encephalopathy, tachycardia. You think it is part of the sepsis? Obesity is 100 kilos. What's his ideal body weight? You didn't write his height? Or no height? So maybe obesity. Okay. Let's look at what we got and start. So patient is confused, tachypneic, low diastolic blood pressure, tachycardic, warm extremities. He is septic. Patient has bronchial breath sound, fever, cough, phlegm. He has right-sided pneumonia. Based on the examination, your bronchial breath sound was on the right side. Patient has SAT 81% on room air, so we'll call him acute hypoxemic respiratory failure. Patient has traveled by car to Las Vegas and came back, possible coccidio, possible PE. Patient has smoking 40-pack year, quit less than 15 years ago. So he's 57. So he's possible COPD, qualifies for screening CT. So how to manage? I would like to start. That's why we identify the problem, so we manage every problem. Let's start with acute hypoxemic respiratory failure management. Remember my DKA case in my year 6 management. So what should you order, including investigations, treatment for this patient? So would you like to start with ABG or start to give him oxygen? So, okay, so how do you manage hypoxemia? You put him on oxygen, titrate, right? So continuous pulse ox. So we'll put him on oxygen, titrate. What's your goal stat? 90%, 94 is okay. So whatever, if you don't think he is CO2 retainer, so 90, 94, okay. What else? Continuous pulse oximetry. What else? Chest X-ray. What else?
He has fever.
ABG.
tachycardia.
So we're just treating the acute hypoxemic respiratory failure. So we talked about oxygen to titrate for 90% or 94%, continuous pulse oximetry, ABG, chest X-ray. What? DNF CRM. So possible COPD. Okay. So this is treatment for COPD, but let's talk about acute hypoxemic failure. So everybody agreed for putting him on oxygen titrate for specific SAT 90 or 94%, continuous pulse oximetry. Put him on, get chest X-ray and get ABG, right? So please, before you call me for hypoxemia, do these things so I can come and get these things. Just if you call me like 3 p.m., okay? So you know this patient is hypoxemic. So this is how you start managing hypoxemia. Put him on oxygen, put him on continuous pulse oximetry, get chest X-ray, get ABG, right? So make sense? So next time you consult me for hypoxemia, I'll find all these things ready. Make sense? So this will make me look forward for the next step. So don't let my note recommend ABG, recommend X-ray. So you are giving me chance to recommend things, but that's okay. Thank you for that. But anyway, so these are things. Where do you want to put him also? ICU. So you need to determine what kind of lines you need for him. Okay, so these are things to think about. So these are things. Oxygen goes at 90%, ABG, continuous pulse oximetry, monitor closely for need of intubation, and the chest X-ray definitely. I just did the X-ray for the pneumonia. Okay, let's manage sepsis and pneumonia together. What would you like to do for him? Antibiotics, blood cultures, which first? Yeah, how many cultures? Which disease you need 3? Infective endocarditis. So 2 blood cultures. So please, after you order the culture, 30 minutes later, look at the microbiology and see, you'll see the cultures are 1 of 3. Dispatch means it was not done. What should you do? Call the nurse. Tell her, please send the blood cultures. Many times they send one and they ignore the second one, and you ignore. They're ignoring. So I come back and why we sent one? Why 2 cultures? Because if your culture comes back with weird organism, you think it's contamination. If it is 1 of 2, you think that. But if it is 1 of 1, you are obliged to manage. Staph epi, 1 of 1, you have to start vancomycin, right? But staph epi, 1 of 2, you may say, okay, the other one is negative, right? And recommended to be 2 peripheral sticks, 2 peripheral sticks, not from the lines. Okay, so 2 blood cultures, start antibiotic, CBC, BMP, lactic acid, procalcitonin, fluid, LR, 30 ml per kg. Give me one more word. Ideal body weight. Okay. If your patient has heart failure or ejection fraction less than 10%, would you give him? He's 100 kilos. You need to give him, if this was his ideal body weight, so 3 liters, right? Ejection fraction less than 100, less than 10%. Would you give him 3 liter bolus? Or give him 1 liter, go and clinically assess and give him another liter, clinically assess and give him another. If your patient is end-stage renal disease and he's anuric, probably 3 liters will be too much for him. Again, give 1 liter, go and assess and give 1 liter, go and assess. So we said we'll send 2 blood culture, we'll start appropriate antibiotic. We'll give appropriate antibiotic. One of the questions yesterday, order antibiotic versus give antibiotics. You have to give, be sure it's given. A few years ago, I saw a patient, if you worked with me in ICU, I round by myself at 7 or 7:30, then I round with you at 9. When I rounded at the patient at 7:30, patient was not hypotensive, was not febrile. When we rounded at 9, patient was febrile. So I said, okay, this is sepsis, patient going into septic shock. And I called the pharmacy to get the antibiotics quickly, and I told the nurse to send 2 blood cultures. Patient potassium was 3, and somebody ordered 40 milliequivalent of potassium infusion. So the nurse was giving the potassium over 4 hours and leaving the antibiotic beside the bed. So you need to be sure your antibiotic is given. What's your window to give the antibiotic? 1 hour, right? Every hour, after the hour, 8% mortality extra. Make sense? Antibiotic should be given. If your antibiotic is not given and your blood cultures are not sent, don't wait for the blood cultures to be sent. Okay, you should send them quickly and start give your antibiotic within 1 hour. So you want to give fluid, you want to give antibiotics, you want to check lactic acid, CBC, BMP, you want to check procalcitonin. Okay, so appropriate lines. Don't forget to place arterial line in case you need monitoring of the blood pressure. Arterial line, not if you need pressure, you need to monitor those, but also central line if you think your patient needs central line. Don't wait until your patient is crashing to start central line. Makes sense? 2 blood cultures, antibiotics based on the pneumonia severity. We'll calculate the severity. You think his pneumonia is severe. So what antibiotics you'll start based on the previous hour lecture? 2 antibiotics with severe pneumonia. So maybe something like ceftriaxone and azithromycin. Sputum culture, CBC, CMP, lactic acid, urine Legionella and strep is severe, so it's reasonable to coccidio antibody because your patient is coming from Las Vegas for coccidio, chest X-ray and ABG. Possible DVT-PE, Fuad, you calculated the score and your score was 1.5, right? So you calculate your Wells score before sending him to CTH. This is his X-ray that we got in the pneumonia case. So we have here right effusion, right infiltrate, right upper lobe infiltrate, right left upper lobe infiltrate, retrocardiac infiltrate, so his multilobar pneumonia. Some labs came back ABG 73250, 60, 25, and 40% with PF ratio 150. This is important to calculate the SOFA. Anybody remembers the lecture from Tuesday? What does he have here? No, the ABG. What's the acid base? pH, steps, numbers make sense. pH is acidemia, respiratory or metabolic? Respiratory. Is it acute or chronic? Acute, you went up 10, pH went down by 0.08, and your bicarb went up by 1. So this is acute hypercarbic. So this is another problem we'll add to, and he is acute hypoxemic. Somebody, you're waiting for the ABG. Now you agree is acute hypoxemic. It's just 60 on 40% if I do. Make sense? When you were out, he said that you didn't mention sepsis as problem. Okay, so he blamed you that he didn't mention sepsis. I'm just trying to, anyway. Okay, labs normal creatinine BUN 21, sodium 142, and his anion gap is 22. Why do you think he has anion gap? Lactic acid is high, right? CBC 12,000, 32% bands, and platelet 90,000. Remember, for the severity of the pneumonia and also for the SOFA. They sent him for CT angio, okay? And CT angio showed no PE, showed the pneumonia, and showed he has emphysema. This is the Wells scores that calculated, 1.5. Okay, we talked about this pneumonia severity, so I will just go quickly through that. Our patient has all these pneumonia severity. So now, after what we knew extra from the investigations that we had, he is sepsis. He's not just right pneumonia, he is multi-lobar pneumonia, and he is severe community-acquired pneumonia. He's acute hypoxemic and hypercarbic respiratory failure. No DVT. We had low probability in the Wells and no PE in the CT. Possible coccidia, we didn't do anything for that. Possible COPD, our CT shows emphysema, so he has COPD, and right parapneumonic effusion based on the chest X-ray. This is how we modified our problem. Okay, patient did not went to the CT angio and came back 30 minutes later. Now he's worse. He's hypotensive, 80/30, and he's sat 92% on non-rebreather. What do you think made him to be sicker? He went into septic shock. If you didn't start your fluid and antibiotic before you sent him for CT, because you were thinking he traveled to Las Vegas, I'm thinking PE, didn't calculate the Wells scores, you sent him for CT, you didn't look for treatment of sepsis, waiting for labs to come back or something. You shouldn't wait, right? This hour in the okay, what else other than not appropriately treating him could have caused his worsening? Laying him down, volume overload from fluids, but we did. If you give him fluid, okay, so if you give him fluid, can be volume overload. Somebody was mentioning something else there. Contrast allergy, so you can get angioedema and you can get hypotension. So anaphylaxis from contrast allergy. So these are so worsened disease. He went from sepsis to septic shock, going from pneumonia to ARDS, and this is how would we go. So now he is septic shock, and nothing else changed from the previous diagnosis. How would you like to manage? We talked about the management of every problem, but now he's in septic shock. What should you do? You give him, you send the labs, you give him the fluid, appropriate amount, 30 ml per kg of LR, ideal body weight, and you start him on the proper antibiotic, 2 antibiotics. What's your next step? Pressors. Number 1 pressor is? Number 2 pressor is? Vasopressin. Number 3 pressor is? Epinephrine. Excellent. When you start vasopressin, when your norepinephrine maximized, correct? Incorrect. When your norepinephrine dose is 0.25, right? So 0.25. Once you reach 0.25, you need to start your vasopressin, right? Vasopressin, everybody is aware, it is a fixed dose. It's not titratable, okay? Fixed dose, vasopressin. So norepinephrine, vasopressin, steroid. When do you start steroid? And what type of steroid? When you are, and how much norepinephrine? 0.25 for how long? Not 4 years, right? 4 hours, right? So 4 hours. So norepinephrine 0.25 for 4 hours. You need to start hydrocortisone. Don't wait until he is on 5 pressors. Okay? Great. Anything else? Yes. Yes, but if he stays 4 hours, you need to add the hydrocortisone. And for myself, I add fludrocortisone too. Not in the guideline, but I will show you the study that showed that. Okay? For fludrocortisone, the problem is it goes only in the OG or PO. And sometimes people who are on multiple pressor, we don't like to feed them because they may develop intestinal ischemia. When your bowel is active, when is your bowel active? After you eat, right? So if you are vasoconstricted with multiple pressors, the blood flow to the bowel is very small. You get them active, they get bowel ischemia. Like Dr. Baweja, when he talked about the ischemic heart, it can be demand ischemia. So increase in the requirements. So great. So let's see here. What would you like to monitor when you are managing septic shock? How do you monitor the brain?
Conscious one.
Yeah, mental status. Okay. How do you monitor the kidney? Urine. What's the good urine output for septic shock? 1.5 to 1 ml per kg actual body weight. Excellent. So if your patient 100 kilos and he is making 30 urine, 30 ml per hour, that's not enough. You need 50 ml per hour for 100 kilos, right? So this is adequate urine output. You follow also creatinine. How do you follow the muscle perfusion? Lactic acid. Okay, great. One other thing that they added in this 2021 was not in the 2016 is capillary refill. Capillary refill time. This is one of the things that you need to monitor when you are managing septic shock, capillary refill time. So this is from the 2016 guidelines, and the previous one, you have some severe sepsis and 3 hours bundles, 6 hour bundles. We don't have 6 hour bundles anymore. So everything is shorter. We have 1 hour and we have 3 hours. So the 1 hour bundle came from this 2018 addendum of the 2016 guidelines. It's very few, 3-4 pages, but they said 5 things needs to be done, and they call it 1 hour bundle. Not everybody believes in this 1 hour bundle, but as I told you, the best treatment of the shock is to do early, right? So very quick management. The 5 things that they had that was not in the 2016 bundle. Number 1 is to measure lactic acid, and if it is more than 2, you repeat it within 2 to 4 hours. Okay. Second thing, obtain blood cultures prior to administration of the antibiotic. This is very important. And how many cultures you need? 2 cultures. Okay. But they also said if you cannot send the 2 cultures, don't wait, don't delay your antibiotic. Antibiotic should be given in 1 hour. Period. Make sense? So don't order the antibiotic and go to your call room. You need to be sure the nurse already started it. Okay, and you need to talk to the nurse, delay the potassium until you get the antibiotic. Third thing, broad spectrum antibiotics. Fourth thing, 30 ml per kg crystalloid. Last thing, while you are giving the fluid, if your patient is very hypotensive, you can start the pressor when you are giving the fluid. Don't wait until the fluid is done. So if your patient's sick, he may die within these 3 hours when you are giving the fluid. So you need to start to increase the blood pressure with pressor. And they also, in the new guidelines 2021, you can start your pressor in peripheral line until you get central line. Okay, this is a new thing from the 2016. It's not in the 2018. Okay, this is the 2021. I will go through the things that we talked about very quickly for the sake of the time. So here they tell you need to use sepsis order set. And I'm working on modifying the sepsis order set. Anybody use the sepsis order set? Anybody knew that there is sepsis order set? So they recommend that you use sepsis order set. You know where to find the order sets on the care?
We use other order sets. We use other order sets.
Okay, you know there's community acquired pneumonia order set.
Yeah.
Okay, so there's sepsis order set, but I modified that 2-3 months ago in the critical care committee that I chair, and I'm waiting for them. I couldn't modify the thing itself, so I sent it to the coordinator, and the coordinator left. Another coordinator came and sent it to the other coordinator to work it. I sent her email because we have meeting on Tuesday, this coming Tuesday, so I want it to be ready before Tuesday. So there is order set for sepsis, and you need to use that sepsis and septic shock order set. So here's what they recommend: not to use QSOFA, and they recommended to use SIRS, NEWS, and MUSE. That's why I told you about the NEWS and MUSE. Okay, but I think using the SOFA or the SIRS is reasonable. You see here, resuscitation should begin immediately, and this is the key for that. Anybody heard about early goal directed study in 2000? No, this is what the 3 hour objectives and or 3 hours goal and 6 hour bundles came from this study. This study in 2000, patients with sepsis or septic shock, they kept them in the ED in specific parts, specific physicians taking care of them, and this study showed improvement in mortality. And I think the best thing that improved the mortality, what they call the study, early goal-directed studies, the early. So, okay, got it? Okay, so here, recommend to begin medications immediately and resuscitation immediately, fluid antibiotics. Crystalloid should be given, completed, your bolus within 3 hours. Okay, so you need to start within the first hour, complete it within 3 hours. It is the first time they mentioned, I looked a lot for that. Is it ideal body weight or actual body weight? In previous sepsis, 8, 12, 16, I couldn't find anything. It's very clear here, it's ideal body weight. And it is LR, not normal sick. Okay? Lactic acid and follow lactic acid. This can be prognostic. And I tell you about a case. So reduction of lactic acid by 20% every 2 hours is good prognostic sign. This was an elderly lady and she came and she was septic. They treated the fluid antibiotic, but lactic acid was still rising and she was intubated. And I went to examine her at 7 o'clock and she was awake on the ventilator. I was examining the abdomen and she grimaced. And I asked her, do you have pain in your belly? She said yes. So I sent her for CT abdomen with contrast and had severe bowel ischemia. She went to the OR and they resected most of her bowel. It was gangrenous. So persistent rise of lactic acid, think about bowel ischemia, severe liver disease. So because lactic acid is degraded in the liver. So if you have that, can happen with severe liver disease. But think about bowel ischemia 100 times when you have somebody you are doing everything else is correcting, blood pressure is correcting, pulse is correcting, but lactic acid is still continuing to go up. Think about bowel ischemia. Don't forget that.
If the lactic is rising and the blood pressure not increasing, they will like use the fluid for
So you
a
are not resuscitating well, and so we probably need to do something more. And
So
I
they
would,
do like the 3 liter or
not the
you
3
just
liter. You need to assess and can add extra volume. So, and I will get to that in the case in a second. Okay. Target is MAP 65. There was a study compared 65 to 80. The only things that differed was increase in the duration on pressors and more arrhythmias with higher pressure being. So did not improve any outcomes. You need to admit to the ICU, everybody knows that. So balanced crystalloid. So balanced crystalloid, LR or plasmalide, there's some other names. I think there's some other one in Centrix, but LR, not SIN, because LR showed improved mortality compared to normal SIN. Before this study came, medical ICU was using normal SIN, surgical ICU was using LR. One of the very few times the surgeons are correct. So they were correct. So LR improved mortality. So okay, so this is first line pressure is norepinephrine. You add vasopressin if your norepinephrine is 0.25 microgram per kg per minute. Once you reach that, don't wait until, because we have study that showed improved outcome if you add vasopressin to lower dose of norepinephrine compared to higher dose of norepinephrine. There was a study was planned on that, and based on that, they recommend to add. Third is epinephrine. Okay, so albumin is another thing that you can add. If your patient has what we talked about, the septic shock plus the Takasubo, heart failure, or he already has history of heart failure, you can add dobutamine or use to the norepinephrine or use epinephrine instead of the dobutamine and the norepinephrine. So this is one suggestion. I will skip 42 because we never use, I'm not sure even what's this medicine, but anyway. For adults with septic shock, suggestive monitoring for arterial blood pressure. So place outline, please. You start the pressure in peripheral. Our guideline here, you can use the peripheral line for pressure up to 4 hours. So try to get a line. If you are not certified in line, call the fellow to come and put a line. Okay. Whatever you need. Yeah, until you get access, right? Your patient is dying, right? What can happen from the, why we don't like pressors in peripheral? You can extravasate and get vasoconstriction and gangrene. How do you treat that if you think your patient's arm is swollen? Phentolamine, right? You ask the pharmacy to give you phentolamine, they will give you a large syringe, like 20 cc syringe with phentolamine in it, and you infiltrate it around this infiltrated area. So you just inject it indifferently to vasodilate to reduce the possibility of gangrene. Okay, again, this is when to start the steroid, when you're norepinephrine or epinephrine, 0.25 microgram per kg per minute for 4 hours. Don't wait until you are on 4 pressors to start, because again, steroid will benefit if you start early, right? So remember early. If you remember one word about the septic shock is early or immediate management. This is what makes a big difference in your care. Okay, so this is the SIP1. SIP1 looked at this bundle, and you think how many of our patients are getting all what we talked about? Give me a percent. Saber, give me a percent. Yeah, 33%, like a third of our patients is getting the full. What's the most likely to be missed? What's the most likely to be missed from this bundle? Early? Antibiotics? No, I hope it's not antibiotics. The most likely to be missed is lactic acid check and repeating lactic acid, 20% and 20%. What do you think is, from all what we mentioned, improved mortality? Antibiotics, to give the antibiotics. That's why be sure, don't go to your room until your antibiotic is inside the patient. Make sense? Within 1 hour. This is the only thing that improved mortality. So 33% got all the items, and most likely lactic acid or repeat lactic acid. But the only thing that improves mortality is giving the antibiotic as early as you can. This is pneumonia. We talked about that. I will not repeat. This is our antibiotic. This patient is severe pneumonia, so we need to double antibiotics. So ceftriaxone plus azithromycin, ceftriaxone plus quinolones, ionicin plus quinolone, ionicin plus. If you think patient is risk of MDR with the multilobar, you think MRSA, it's okay to start coverage. He's very sick. You can add coverage for that if he has any risk. Norepinephrine is first line for what type of shock? Septic shock, right? So epinephrine is first line for anaphylactic shock, right? Phenylephrine, if you use it, so phenylephrine and vasopressin don't increase your heart rate. So if you have anybody with serious arrhythmia, not sinus tachycardia, so somebody is VTAC, SVT repeatedly, so serious arrhythmia, you can switch your pressors to phenylephrine, and they don't help much, but they only, if you have serious arrhythmia, you can use them because they don't increase the heart rate. Dopamine, especially if you have heart problems. Dopamine also, you can use it, and epinephrine. Which shock other than cardiogenic shock? You know, 2008, dopamine was #1 for septic shock with the norepinephrine. Then data showed it worsened mortality in septic shock. Which patient that has hypotension and you prefer to start dopamine or epinephrine? Okay, until you have bradycardia. So shock from bradycardia from drug overdose or so. Beta blocker, calcium channel blocker. Dopamine and epinephrine are the things that can increase your heart rate. So this is to use. Vasopressin second to norepinephrine and septic shock. This is the study that showed LR is better than saline. In general, in all patients, not just septic shock, it reduced the adverse kidney outcomes. But in the group with septic shock and sepsis, improved mortality. Makes sense? So this study, what made everybody follow the surgeons using LR. Now your patient is intubated, sedated, and received 3 liters of LR, started on pressors. Now he's on 3 pressors, MAP 55, urine output is 30 ml. Is it enough? No, we need MAP 65 and urine for 100 kilo patient, 50 ml per hour. You sent to blood cultures and you gave the antibiotic. What's your next step? Steroid. We are very late for the steroid action. Make sense? So now he's on 5 pressors, MAP 65, and he's maximized on the 5 pressors. His urine output is 50 ml at goal, and your lactic acid is 4, getting down. But you are maximized on 5, so you need to start the steroid. This is a study that showed 50 Q6 hydrocortisone plus 50 microgram of fludrocortisone improved mortality of patients with septic shock. I'm not sure why they didn't take this study. Hydrocortisone is a good mineralocorticoid. That's why you don't use any other steroid in septic shock. Hydrocortisone. Why hydrocortisone? Because it's the strongest steroid that has mineralocorticoid effect. The first study was, I think, 2003. They looked at the relative adrenal insufficiency and they used hydrocortisone and fludrocortisone. Then all other studies dropped the fludrocortisone and said hydrocortisone has good mineralocorticoid effect. You don't need the fludrocortisone until this study came and they looked at it in the same month or two different or 2 months apart. This study came after the study that used hydrocortisone 200 milligram a day, not more than 200 in septic shock. They use continuous infusion in this study, but you don't have to use continuous infusion because you will use one of your ports just for cortisone, and you are limited. And for these people are maybe requiring 2 central lines or something like that. So this study showed that patient mortality did not change, no difference compared to placebo, but it showed 1 day less of pressors. If you added hydrocortisone alone, 1 day less, from 4 days on pressor to 3 days on pressors. Also, extubation was 1 day earlier, but patient needed to be reintubated again. So this 1 day earlier extubation went away. So the only thing, the benefit was 1 day less on pressors from hydrocortisone on, which is not bad. To reduce your pressors 1 day is good too. One surprising thing that was GI bleeding was less. I'm not sure why. Steroid can increase your GI bleeding, but maybe it reduced the stress that the patient had and reduced. But this is just one study, I'm not sure. Okay, hydrocortisone 50 milligram Q6 was given, fludrocortisone 50 in the NG tube. Pressors weaned, and now 2 days later, he's off pressor. Good job, good job. Not always everything goes in the good way. So what if your patient still MAP 55 on norepinephrine, vasopressin, epinephrine, dopamine, and phenylephrine, and cortisone and fludrocortisone? Any options? ECMO? Yeah. So what do you use to lower your blood pressure? Your patient with high blood pressure. This inhibitor. So somebody smart said, dopamine, epinephrine, norepinephrine, they all work on the same receptors. So if one is not working, why adding the second one would help? Vasopressin work differently, right? So he thought, okay, we give ACE inhibitor to decrease the blood pressure. What if I give ACE agonist? And they started several years ago this angiotensin receptor agonist. I used it one time. A difficulty getting the hospital to approve it here, and I got it from Research Medical Center. It's not formulary here. And we called them and we sent a card to get it, and we got it. And we started. Patient was on 5 pressor. She went only on norepinephrine and the angiotensin 2. She didn't make it later on, but at least we win. The pressors and blood pressure was stable for some time. They worried here about DVTE, increased risk of thrombosis. That's what made them not to approve it here. But who worries about DVTE in patient who's dying? So if I don't, 5 pressors hypotensive, if I don't use it now, patient will die in a few hours. So when will we can give DVT prophylaxis, can even anticoagulate. So anyway, who's MAPID? There is a separate sepsis campaign. I was looking at 2018, a 2016 update in 2020. And every time I give shock lecture, I give this lecture for year 6 students every door rotation. So I was looking for update because it comes every 4 years and didn't come in 2020. Then I found there is sepsis campaign for pediatric. I didn't read it. You may need to read it.
It doesn't matter because you can pay every pediatrician $1 million and they still won't use LR.
Okay.
Especially in a pediatric.
I'm not sure what's the guidelines for the pediatric thing. But there are a lot of different things. So it's
Basically,
still
it's just
LR in pediatric.
extrapolate all of our data. So if R says, if adult says to use LR, we're supposed to use LR,
Okay.
but
But there are some differences. I told you the oscillator has benefit in pediatrics and worse in mortality in adults for patients with ARDS. So patient is better weaned off pressors, but on day 5 he's on no pressors, but he had 5 loose stools, started to have fever and hypotension again. You think about. So just I will not go through it. Just I want you to know there's 2017 guidelines for management of C. diff. You need to read that. And if you are interested to, if you cannot find it, you will find it everywhere. So they divide the severity and the treatment will differ based on the severity. And what if your CT angio showed PE? TPM? TPA? Not TPA. So I'm hungry or something. So TPA, okay. So if you have shock from PE, so if your patient septic shock and you think his hypotension from the shock and you find DVT or PE in CT angio, you shouldn't give the lytic. Giving the lytic if you think the shock is from the PE. Make sense? What's the major problem with the lytic? Break, right? So resume immediately. So when do you start heparin after TPA? For the sake of the time, there are two theories or two schools. One, start heparin without bolus immediately after the TPA is done, and other people check the PTT level every 4 hours. I'm from this school. Every 4 hours, when the PTT time is less than double the upper normal of your normal PTT, I start heparin with no bolus. Everybody is familiar with the contraindications, indication to give TPA. Absolute contraindications are the ones that you should think about. I just want to mention acute bleeding is contraindication except menses. So the period, a lady and has her period during that time has PE and hypotension, give her the lytic and it's a board question. Okay. Okay. Case 2.
So can you give mechanical thrombectomy
for this patient? Mechanical embolectomy for just PE, if you have it available. And also if you have available, Dr. Baweja sometimes do that, but I don't think he started. He gave like a local lytic, so through the cath. So he was trained to do that. But I think in Luke's and Research Medical Center, they can do the mechanical part. So mechanical part will give you good option, especially if your patient has some bleeding risk. Okay, case number 2. Let me be sure we are not away from the schedule. So we have for the shock up till 4 o'clock. Okay, still have 30 minutes. Second case will reflect what you had in the first lectures from Dr. Bawi on Tuesday. So I'll read the case and we'll do the same thing on the other side from the page that you have. 60-year-old man with known coronary artery disease presented to the ED with retrosternal chest pain, started while he was working in his backyard 30 minutes ago. Pain is crushing and associated with diaphoresis. Past history of the usual hypertension uncontrolled. Usually blood pressure runs 160/100 on 3 medications. Coronary artery disease, hyperlipidemia, diabetes. Quick exam showed his blood pressure is 110/70, orthopnic, sat 86% on room air, elevated GVDs, tachycardia 110, gallop on the heart, bilateral basal crackles, bilateral lower extremity edema with cold extremities. Troponin was sent, EKG and stat, portable chest X-ray were done. Okay, 2 minutes, write your problems. Okay, but remember the lecture is shock, not sepsis, okay? 1 minute. Okay, are we ready? Who has 3 problems? 3? You have 15? Okay, so did you copy the links? Okay. So 3 problems. Okay, let's start with 3 problems. Tell me, number 1, shock, right? Why do you think he's in shock? And this is based on mainly the PE. Everybody's familiar with what's massive PE. Massive PE is saddle embolus, correct? No, it's not correct. So saddle embolus does not mean massive PE. Massive PE is PE that's causing hypotension, hypotension, like shock, 40 points reduction in systolic blood pressure, bradycardia below 40. One more. Let me give you a hint. I'll not say it this time. What did you have last lecture yesterday? ACLS, PA arrest, right? So you look at the P, so the T's, right? One of the T's is PE, right? Thrombosis. So this is the massive PE. PE that give you shock, hypotension, bradycardia, persistent bradycardia, less than 40. 40 points drop in your systolic blood pressure and cardiac arrest. This is the massive PE. Make sense? So he dropped, he's persistently 160 over 100, so he probably has shock. What do you think he has shock? What type of shock you think he has? Cardiogenic shock, okay. So number 1, cardiogenic shock. Tell me about the other 2. Acute hypoxemic respiratory failure. He's setting less than 90% on room air. Excellent. 3. Which side, left or right or both? Why do you think he's left-sided heart failure? Bibasal crackles, orthopnea, edema is not left side. Gallop. If you hear the gallop on the mitral valve, okay? So why do you think he has right side? JVD, edema, JVD. Anything else? We didn't mention anything about the liver in this case, and we need to add some hepatocellular reflux. Okay, great. Just by the way, everybody knows the scratch test for examining the liver? Scratch test? Liver examinations? Okay, so you can tell them about that after the course, okay? So, scratch test when you examine the liver. This is very helpful in obesity. Okay, so who has 4? Who would like to add extra problem? Pulmonary edema, which is part of the left heart failure.
Did you add that?
He didn't. So would you like to add acute coronary syndrome?
Yeah.
So chest pain, crushing. Make sense? Great. So you think he's acute coronary syndrome. Let me give you his EKG. So he has STEMI, right? Where 2-3 ABF. Okay.
Yes,
Reciprocal B1, B2. Then maybe some elevation here too. Yeah, maybe also posterior. Maybe right ventricular. If you have inferior and posterior, think about right ventricular, right? So there's some anterolateral changes too. Okay, chest X-ray. Wow, what do you call that? The other word for wow? Pulmonary edema. Other name? Bat wings. Yeah, bat wings. So the bat is the heart, and the wings of the bat is well, the body of the bat is the heart. You see, it's like a bird. Head, body, wings. Pulmonary edema. Bat wings X-ray. Makes sense? Great. So this is what we have: acute hypoxemic respiratory failure. EKG shows acute MI. Patient has hypotension compared to his baseline, so he's probably in cardiogenic shock and tachycardic cold extremities, so he's in shock. Has gallop, bilateral basal crackles. X-ray shows pulmonary edema, so his left side heart failure. JVD and bilateral lower extremity edema. So this patient has all these problems that we talked about. Make sense? Let's manage him. How do you like to manage? Aspirin. Aspirin and what did we say here? I heard Plavix. Aspirin, ticagrelor, heparin, oxygen. What's the new changes in the oxygen in the last few years? We used to give oxygen to everybody. Now oxygen only if your SAT is below 90%. So if your SAT is below 90%, you start oxygen. You remember the MONA? Morphine, or you can use fentanyl, diluted, whatever. Or, but oxygen only if the SAT is less than 90%. Would you give him nitroglycerin?
No.
Why no? But it may have RV, right? So who else shouldn't get nitroglycerin? So patient is using phosphodiesterase inhibitor resource. Then the aspirin, now we add another dual antiplatelet, right? So he's STEMI, so probably he will not go for cabbage within the next 5 days. So probably you need to start the ticagrelor. And what else you need to do? Call for cold STEMI. How do you call for cold STEMI? We talked about the heparin. Yes, correct.
Interventional cardiology number.
You have the number. I will put it there for you too. Or you can call the operator and tell them activate cold STEMI. I think they distributed some algorithm for you. I didn't look at this one. So it may be interesting if somebody has that algorithm, you can send it to me an email just to see what they are asking you to do. Probably this is coming from cardiology. So I think part of this algorithm, because there was a little bit high false codes and so. But one thing I want you to do is when you have STEMI, not to call the cardiology fellow. This is, don't call the cardiology fellow. You need to call for cold STEMI. Calling the cardiology fellow, he will look at the EKG, then he will tell you that what I think. Then you contact that, you are losing time. You should be in the cath lab as soon as you can, right? So don't call the cardiology fellow. If you want to call somebody, call the intervention cardiology, the number that Dr. Balija gave you, or call for cold STEMI if you are convinced. Is there anything in the algorithm to call the cardiology fellow that you got? No? Okay. So it's not like the ICU fellow. You need to call the ICU fellow. But in a STEMI, you need just to talk to the intervention cardiology directly. Great. So oxygen, call for code STEMI. This is the number. I think it is the same number that you got from Mr. Bawija. Unless they changed the number from last year. Anyway, you do right-sided EKG to look for right infarction. You do V7, 8, and 9 to look for posterior infarction. Aspirin, morphine, or other narcotics. Ticagrelor loaded. So if you think STEMI. So, but I always discuss with the intervention. Do you want me to load with the ticagrelor? Don't give Plavix. Dr. Bawija 2 days ago told you Plavix takes a long time to work, and there are certain of people cannot convert the Plavix to the active metabolite, so they will not benefit from that. Heparin drip started and no nitro, and we discussed that. Loaded with aspirin, ticagrelor, and heparin IV started, was given pain medication. Now blood pressure dropped to 80/55 with cold extremities. Troponin came back to, Dr. Bawija talked to you about that. You don't need 600 troponin to say they are usually in the low high. So, okay, now you have the sensitive troponin. So requiring 10 liters of oxygen now. What should you do? Call the fellow, call the ICU fellow. Okay.
But he should go to the.
He should. You already called the intervention cardiology, but he's starting now low, and he is requiring 10 liters. And this was discussed 2 days ago. You forgot what you asked. So you said, somebody said that he may not be able to lay flat, his orthopneic. Have you ever heard the anesthesia stat cath lab? This patient probably should have been intubated before he goes to cath lab. This patient, I would intubate him before I send him to the cath lab. Traveling with the elevators, needs to lay flat in the cath lab. You saw his chest X-ray, horrible, requiring more oxygen. So if you don't intubate him, he will be intubated emergently in the cath lab. Intubate him when he gets everything done. Pulmonary edema resolves, try him, extubate him. Make sense? I would intubate this person. This X-ray, you will not tolerate laying flat in that cath lab. More hypotensive, you need to start some pressor. I may discuss with the cardiology what pressor they want. Do they want norepinephrine versus dobutamine versus dopamine, what they prefer? So pressors. What if he goes to the cath lab and he is still hypotensive after opening the arteries? What else can help the blood pressure? Balloon pump. And just quick question, because sport question, what's a common contraindication to give put balloon pump? Aortic regurg. This is, they love that in the board. Okay, what else other than we have aortic balloon here, but if you are in loops, they may have other things. They may have. Okay, so these are things that will help the blood pressure until things get better. Any questions about the shock? This is something to help assist the heart. So it's a device. So this is the cardiogenic shock. Definitely, if you have hemorrhagic shock, you will replace the blood. But quick question, they love in the board. Patient came with acute GI bleed. Hemoglobin 10. And he is tachycardic. Blood pressure is 120/80. And he vomited 1 liter of blood in front of you. Would you transfuse him? Yes. Don't say hemoglobin is 10, our cutoff is 7. This is not for acute. He vomited 1 liter of blood. How much blood do we have? 5 liters, right? And for he has GI bleed, his blood is not good quality like yours. His hemoglobin is not 14. Maybe his baseline is 8 or something like that from his previous GI bleed. So somebody is vomiting in front of you, tachycardic. Give him transfusion. Don't wait for the next hemoglobin or to drop below 7 to transfuse. 7 is not for acute bleeding. Make sense? What lines you need to put in him? Central line, correct? Not central line? Two large bore peripheral catheters, 14 gauge or so. Make sense? If you want to put central line, what do you put? cordis. Okay, so the central line, the triple lumen is 7 French. Let me ask you a quick question. Which is larger, the millimeter or the millimeter? The first one. Anybody goes with the second one? So the millimeter is 3 French. The French is 1/3 of millimeter. Your triple lumen catheter is 7 French. So your triple lumen is less than, is 2 point something millimeter. So every lumen is less than 2 millimeter. So to give blood through this very small, don't think triple lumen is better to resuscitate, right? Large bore peripheral catheter is how you resuscitate hemorrhagic bleeding. Board question. If you want to place central line, you place a cordis. Cordis is probably like the size of a pen, okay? And it's 1 lumen. You can dump 1 liter of blood in every minute in the cordis. Make sense? It is short, and this cordis was made initially to pass Swan-Ganz through it. Okay, so you place the cordis and pass the Swan-Ganz. Okay?
Are we using this cordis? I've never
Yes. And also, after you place the cordis, patient is stable, you need more lines, you can float triple lumen, specific triple lumen in it instead of the Swan-Ganz. And you use it as triple lumen. You want to start PPI, you want to start, but after you resuscitate your patient with the blood, you can use the cordis. Any questions? So we are 10 minutes or 5 minutes ahead. Would you like to take the break, the 5 minutes break now? Or do you want me to talk about non-invasive positive pressure ventilation and take the 5 minutes break before the test? Who would like to take the break now? Raise your hand.
We're 10 minutes ahead, right? We can take a 5-minute break now, a 5-minute break.
We are 10 minutes ahead, including the 5 break. So if you want to get 35 minutes for the test, so we should take only one 5 minutes. Just for the sake of people who are slow like me answering questions. Okay. So break now? Yes, okay. 3 minutes break because I know it will take 5 minutes if I say 3. Yeah. Yeah, I know. I don't think I have seen
I have a question for you. So when you're talking about allowing the patient for shock, what about the capillary refill? Can you
This is
explain that?
something we added. So if you have delayed capillary recall,
Like, which is what time? Like 1
usually
second, 2
6
seconds?
seconds or
Oh, 6
so.
seconds.
So yeah, it's your maximum. So if you have 10 seconds, if it gets better, so you look for lowering
Okay.
time. So
Because we have that in our like meta tech now too. They have capillary refill time and the output that's
Right.
out to second.
right.
Transfer was 6
So
seconds.
this is your maximum.
Okay.
5, 6 seconds. maximum.
But if it's more than
Or,
that,
yeah,
you're saying that it's
very
bad.
long.
No,
Even if it is 6 seconds, you look for 5 or 4. So 4 is good capillary recall. So if you look at yourself,
Yeah.
it's 2-3 seconds.
Yeah.
But anything wider than 5,
But are
6
you
is
using both hands and both feet?
But in short, you are looking for improvement.
Yeah.
It's not just absolute value. If there's initially 6 seconds, you're looking for 5, 4. Lactic acid 8, you're looking for 6, 4.
Yeah.
I looked it up the normals in 2 seconds.
Yes, I thought it was like, I mean, it's less than 2. Not 6.
You're correct. Okay, are we ready? Okay. Last lecture, we'll spend the next 30 minutes talking about non-invasive positive pressure ventilation, because this is something that you will use a lot in the hospital. And I'll try to answer your questions that you are thinking about. And if you have any further questions that I didn't explore, let me know. First thing here in the top thing, it can be written as non-invasive positive pressure ventilation, NIPPV, or can be written as NPPV. Okay. Again, I have no disclosures. So I hope by the end of this 30 minutes, we will understand what initial settings, what modifications we should do on the settings based on the problem that we have. And I'll give you some small quick scenarios about specifically EVAPS and BiPAP, what changes you need to do, what you should do, what you shouldn't do. So again, positive pressure ventilation is different from the ventilator. It's non-invasive. So you use mask And this mask, they call it interface. So when you hear the word interface, this means the mask you are using. So these are the questions that I have. And if you have any further questions, and we'll try to answer these questions quickly. What diseases benefit from non-invasive positive pressure ventilation? Does it help COPD exacerbation? How about asthma exacerbation? Is it indicated for acute pulmonary edema? Does it work for pneumonia? Does it work for ARDS? When to start non-invasive pressure ventilation in acute settings? What mode should you use, CPAP or BiPAP or EVAPs? Look here, BiPAP does not have I. It's BPAP. The one that has I, BIPAP, is a specific mode in a specific machine. But BiPAP should be written without I. Okay? This is the proper how to write BiPAP, BPAP. What mask works best? What settings should you start? Does BiPAP setting differ if the patient has sleep apnea on CPAP? Is CO2, if CO2 is high, would you correct CO2 to 40? When to extubate patients from ventilator to non-invasive positive pressure ventilation? What to do when patients refuse non-invasive positive pressure ventilation? So RT will write patient refuse, and that's it. Then patient comes to us and to the ICU next day. So why? Because he refused, nobody was notified. So should we feed patient with non-invasive positive pressure ventilation if they are on it all the time? Can you restrain patient on non-invasive positive ventilation? And I didn't want to wait until I finished the lecture, so I just answered that. Never restrain a patient on non-invasive positive pressure ventilation. He's vomiting, cannot take the mask off, right? Others, based on what you think. Okay, so the different types of masks in general, we'll go through that quickly. Oronasal mask, or what we call face mask, which cover the nose and mouth. Nasal mask cover the nose. Nasal prongs or pillows. I think Saber, you had patient with, or this wasn't you? Didn't like claustrophobic, even didn't like the nasal pillows. So for face mask, or we call hockey mask, or sometimes they call it total face mask, covers from above the eyebrow to the chin, so the whole face. Helmet mask. Have you ever seen helmet mask? So this is one of the things that got some popularity during the COVID period. It helps oxygenation. Patient can eat with a straw, so can drink some drinks or drink something. He can talk, communicate. So it improves hypoxemia, but may worsen the carbon dioxide. So helmet valve is not for patients with hypercarbia. They accumulate carbon dioxide. Even if you put them on ventilator through the helmet valve, you cannot guarantee that they get the tidal volume that you want, because it's a plastic thing that is distensible, variable distensibility, so you may not get the same volume with every breath. Again, these are the types of masks. There are some I never saw before, like this 5 things, or like somebody is smoking shisha or something. This is how the helmet valve looks like. And this is patient access thing. You can, there is some access ports here, so you can get him some fluid to drink. He can talk and things like that. So this is from up-to-date comparison between the different masks, the nasal and the oronasal and full face, which is the hockey mask. You see, permits eating the nasal mask, but also they can aspirate. People who are naive to have machines, big part of the air goes to the stomach. They get distension. And you feed them or give them NG tube or Dubhoff, and you feed them and they vomit, and they have full face mask and they cold. So anybody on continuous non-invasive positive pressure ventilation, please don't feed and don't place Dubhoff. Which is the best? Conclusion, the best is whatever the patient can tolerate. Because if he's not tolerating it, and though it is less beneficial. So somebody not tolerating the full face mask or the face mask, and you put him on nasal mask, this may be better than doing nothing, right? So full face mask is the most likely to help your carbon dioxide, and similar to that. So I'm not sure this study mentioned full face mask. I'm not sure they are talking about the mask that cover the nose and mouth or the hockey mask. So these are the ones that may improve your carbon dioxide better than the nasal trunks and the nasal mask. So many of the patients also, when they are severely ill, they mouth breathe. So if you're using nasal mask, they will not get the pressure that you want. So the helmet is good for hypoxemia, bad for hypercarbia. So hypercarbic patient, you can use the hockey mask or the oronasal or the face mask, not the helmet. Patient with hypoxemia, helmet is the best, and others are okay. This is the conclusion I just mentioned. The best mask is the best mask tolerated. How tight? The straps, you can pass one finger between the strap and the head. One finger here, one finger here. This is how tight you need your straps on. Patients naive and they're refusing, I usually don't put the straps at all and start using it during the day. And I tell the patient, hold the mask with your hand. So patient will be feeling that he controls the mask, he can take it off. And he will take it off after 2-3 breaths. Then he will put it 5-6 breaths. Then he will put it longer. Then once he starts to get used to it, I can put the straps on. So don't just put the straps and he will be suffocated. Then he will refuse to use it again. You are giving him trauma. Anybody try to put CPAP machine on his face?
Yeah, one night at like 2 a.m. this call from RD, patient is not applying CPAP, this being put on the.
So you use it yourself?
Yeah, I went there and asked him, please.
So if the patient is refusing the CPAP and you think it's helping him, use it for the doctor. So doctor.
I mean, he was sleeping and he was getting hypoxic, and it's the oxygen saturation went to like 70%, and he need that.
So you put it on him, not on
Yeah.
yourself. Okay. Okay. I misunderstood it. So. Even 5 pressure is too high. It's too high. Make sense? So if the patient is claustrophobic, I may try nasal mask. You will be surprised sometimes patients who are claustrophobic may be okay with the helmet, with the hockey mask, the one that covers that, because they don't feel it is tight on them. Helmet may be less claustrophobic, although I'm mildly claustrophobic. I don't like this bag they put us. I think we have some due mask fitting. So this hood that they put there to test the taste and things like that, I cannot tolerate that long time. So I'm not sure also they will tolerate the helmet now. Chin straps, when do we use it? If we use nose mask or nasal pillows, this is more likely we use for patients with sleep apnea. We use chin strap if they cannot tolerate the face mask and they are mouth breather. You use chin strap to keep the mouth closed when they are using nasal mask and the nasal pillows. If your patient has allergic rhinitis on the long-term treated, and even in the hospital, if the patient says, I'm not tolerating the mask because I have congestion, I had a few patients like that in the last few months, I start some nasal steroid and think to help them to tolerate the mask. Humidification, cold or heated humidity for sleep apnea patients improves the patient use. So one of the things. Be careful with our large machines that we have the V60 machine here. This V60 machine, if you add heated humidity, it will deliver too much water to the patient, so they don't like it. So you don't see humidification with our V60 machine. The only time you use heated humidity if you use the V60 machine as a source of high flow oxygen. It can go up to 80 liters per minute, more than the Evo. Evo goes to 60 liters. The V60 machine itself can be used as high flow oxygen up to 80 liters per minute, but you have to add humidity and heat to it. And this can be a small piece they connected to the machine. CPAP is continuous positive airway pressure, but you'll be surprised they don't get, you put him on CPAP of 5, he will not get 5 all the time because he is breathing. So he will go below the 5 and above the 5 with every breath. So when he inhales, he will go below the 5. When he exhales, he will go above the 5. But his average will be the 5 that it. Bi-level, pulsive airway pressure, or BiPAP, is, as I told you, it's written BPAP, not BIPAP. Then you have the average volume assured pressure, or the AVAPS. And this mode, I prefer that you use this mode for patients with hypercarbia, because you tell the machine, I want this type of volume, the machine will give you this type of volume. Okay? No data showed AVAPS is better than BiPAP. So no data showed it is better. But this data in research for people who understand the BiPAP and use proper setting, not just put the BiPAP setting and leave. Okay? So you need to be sure you are getting the proper setting. Again, this is a CPAP. Your patient, if not on room air, when we all breathe, we go down and up. When we inhale, go down. Negative pressure to full air, then positive pressure to exhale. Patient on CPAP 5, his pressure will be down in expiration, a little bit up in expiration. So it will be a little bit fluctuating above the number you want. Put patient on BiPAP 10/5. This is different from ventilator. When you say patient BiPAP 10/5, this is IPAP 10 and EPAP 5. But when you have patient on pressure support on the ventilator, we say 5/5, this will be equal to BiPAP 10/5. Because in the ventilator, it's 5 pressure support above the 5. So during inspiration will be 10 and expiration will be 5. So pressure support 5/5 is equal to BiPAP 10/5. That just is named. With the BiPAP, you mentioned IPAP and EPAP. Contraindications for BiPAP, anything coming from the patient out. Nosebleed, hemoptysis, vomiting, copious secretions, fracture of the head. When you get head trauma, patient has a lot of bruises. It will be torture if you put some machine on his face that's hurting, right? Important than that, patient, if he has clear water coming from his nose, what do you think? CSF leak. So fracture cribriform plate, and you put him on non-invasive, you are pushing nasal bacteria to the CSF. Make sense? So patient who's unconscious from non-respiratory etiology, Glasgow score 10 or less, don't put him on non-invasive. Okay? Because they may vomit with the machine, they will not be able to remove. But if patient hypercarbia causing the conscious problem, you can put him on that and observe him closely, but don't feed him. Indication: acute and chronic respiratory failure. Chronic respiratory failure, like patient with COPD, you can use it at night. Doesn't show improved mortality or outcomes, but may give them some rest during the night. Neuromuscular disease, myasthenia, ALS, obesity, hypoventilation syndrome, and sleep apnea are probably the most common chronic etiology to use it. You can also extubate to non-invasive positive pressure CPAP or BiPAP or AVAPS. This is from UpToDate, tells you the difference between the all and what to start initial settings, and we'll talk about that in a second. This is important, and this is the most common cause of BiPAP failure. That's why I want you to use the AVAPS mode if you don't have time to stay with the patient to adjust the volume. And you adjust the volume by adjusting the IPAP. So say you want tidal volume 400 for this patient, and you put him on pressure 10/5, and he's getting 300. You need to increase the 10 by 2 and stay with him, increase it another 2, until your patient gets the tidal volume you want. If you don't have time to do that, let the machine do that for you. Put him on AVAPS, tell the machine I want 500 tidal volume. The machine will titrate the IPAP to the volume until you get the volume that you want. So quick, just wait for 3-4 breaths and watch. Okay. With the BiPAP, it's not like the ventilator, you have fixed volume. So you will have volume in one breath 300, next breath maybe 400. So don't say he's 400 for one breath, this is what I want, you leave. Next breath he may get 200. So you need to observe for a few breaths and be sure it's persistently getting the volume you want. So usually we need 6 to 8 ml per kg. Some diseases we need 10, up to 10, like neuromuscular diseases. If you increase the EPAP for any reason, So say you are on 15/5. Patient is hypoxemic and you want to increase his EPAP from 5 to 7, increase the 15 the same amount. So you can keep the pressure support the same, so you keep your tidal volume the same. Got it? Low oxygen on the BiPAP, what should you do? If you have room to increase FiO2, you can do it, or you increase the EPAP. EPAP is equal to the PEEP on the ventilator. Patient on BiPAP, 10/5, he's hypoxemic, he's on 40%, you can increase the 40 to 50, to 60, to 70. He's on 100%, you can increase the 5 to 7. But when you increase the 5 to 7, increase the 10 to 12 to keep the difference the same, so keep your tidal volume the same. AVAPS, this is somewhat smarter machine. AVAPS is a mode. The machine itself, this blue machine that we have, is called D60 machine. So the AVAPS is a mode. BiPAP is a mode, right? It's not the name of the machine. So the machine itself is called D60. It may have different names in other hospitals. So AVAPS, you need to order EPAP. Patient naive doesn't have sleep apnea, start with EPAP 4 or 5. IPAP minimum should be 1 or 2 above your EPAP. IPAP maximum, you will never be wrong if you go to the maximum pressure 40. Okay? So if you want setting for anybody, rate, start in the low T, 12, 14. Okay? So patient naive, has hypercarbia, start EPAP 4 or 5. IPAP minimum 6 or 7. IPAP maximum 40. Put the tidal volume 6 to 8 ml per kg and rate of 12. Oxygen to keep your sat whatever you want, 90% or so. Most of these people are hypercarbia. Make sense? IPAP maximum 25 versus 40. If the patient has obesity, I probably would go to 40. Patient is very tiny, no lung disease, you can go to 25. And I will show you scenarios, what changes you need to do. Patient on sleep with sleep apnea on CPAP 10. He is not naive to the machine. He's using CPAP 10 every night. I would put his EPAP on 10. EPAP on 10. Then IPAP minimum 12, because you are not just treating the hypercarbia, you need to treat the sleep apnea. Does he need that all the time? Probably not. He will need that EPAP of 10 when he sleeps. But nobody will put him on different setting, especially with the COVID. Our T's are very busy. If they put him on the EVAPs, they will leave him till the morning. This is how the D60 machine looks like. Let me use the mouth here. So this is, we put this patient on 560 tidal volume, EPAP of 4, IPAP minimum 8, IPAP maximum 30, and he is on 25%. And we put him on a rate of 16. This white dot line is the tidal volume that you want. If you look here, your patient is getting 521 and his required tidal volume is what? 560. So he needs higher tidal volume. This is what you are getting, your IPAP. So you are between 8 and 30, but your patient is getting 15. Every minute, the machine by itself, if the tidal volume is less, this 15 will go to 16. If the tidal volume is not the 560 you want, will go to 17. If you get 600, we'll do the opposite. This 16 will go to 15, then 15 go to 14 until you are. So you'll find this. Patient does not qualify for EVAPS machine at home and you want to send him on BiPAP. Look at this pressure. This pressure on the right top. So if this patient will go home and I can qualify him for BiPAP, not EVAPS or Trilogy, I can send him home on 15/4. If he's getting the volume with 15, so I can send him. So I tell the fellow or the resident, go and put him on the EVAPS machine, see how much IPAP he needs to get the tidal volume that you want. And we can order for this patient who's getting 560, 15/4. This is the setting of BiPAP that you can send him on. This patient is the opposite. He's getting higher. So he's on 15. This 15 will go down. Make sense? Who will do that? The machine. So you don't have time to do that. So the machine will continuously assess. Patient is more awake, pulling more tidal volume. Patient is more sleepy, more sedated, putting less tidal volume. So this is the benefit of this machine. So we'll work on this IPAP pressure within the range that you put to get you the tidal volume.
So we use the AVAPs for all the patients when they are diagnosed, and then after the numbers, we do at home. Just check it about that.
If he doesn't qualify for Trilogy or EVAPS machine at home, you can send the patient on EVAPS and Trilogy, but needs more qualification because $1,000 compared to $10,000 or $15,000. So that's why insurance.
But in the ICU, AVAPs for all patients. Right?
So what I do, unless your patient is only hypoxemic, you can use only CPAP only. Use BiPAP, that's okay. Makes sense? But EVAPS, if you need volume to wash carbon dioxide, this is the main thing. Okay, troubleshooting. Your patient can auto peak on the EVAPS, like the ventilator. So don't give him large tidal volume and fast rate. Okay? Give him 6 to 8 ml per kg. COPD patient who's acute hypercarbonic respiratory, give him 6 to 8 ml per kg, ideal body weight, low rate in the 12. If you increase the rate or increase the tidal volume with the EVAPS, he can auto peak, can get pneumothorax. So same thing like what you talked about in the ventilator lecture yesterday. Reduce the interface leak by adjusting the masks, because the more the leak, the V60 machine can compensate hugely for leak. But what will happen will give you longer inspiration to get the tidal volume, because the machine will feel that patient is not getting the 560 we wanted. So we'll continue to give him inspiration until he gets that. So you will prolong the eye time. Prolong the eye time will reduce your expiratory time. Most of these patients have COPD. Make sense? Improving patient comfort and reducing anxiety. You need to explain, as I told you, I like the patient to hold the mask by his hand before I put the straps if he's naive to machine. You will see that a lot. Patient is severely dyspneic and you put him on the EVAPS machine. Once he gets better, he refuses to use it. The smaller group, they get better, you want to win, and they refuse to come out, they are afraid to come out. So I'm sure you will see that sometime. But the more likely, after they get better, they don't want to use it. Okay? So we need to talk to them, explain why it's important for them. And I usually explain every day, and they don't use it, but you have to explain every day. So important to explain to them why you are using this machine. You can switch to different masks. Patient is not tolerating full face mask, like face mask. Get the hockey mask, get the nasal mask. We don't have nasal pillows here in the hospital, but sometimes patient with sleep apnea, and they tell me I like to bring my machine, and I tell them, okay, bring your machine and use it. So we allow them to bring their machine, their mask to use it. Usually we throw away the masks after they leave. Same thing in the sleep lab. We don't use the mask twice. So be sure your patient takes the mask and the hose, not the machine, with him home on discharge. Okay. Same thing for the IS and the acapella and things like that. We throw them out. So be sure your patient takes them out. Peak flow, all these things, give it to the patient when they leave. I rarely use sedation. We see sometimes in the ICU or PCU patient is put on Precedex. So, but be careful because Precedex can get him too much sleepy. It doesn't suppress the breathing, but too much sleepy. Many times I found, especially at night, patient is completely unresponsive. This is not what we want. We want to little bit, don't use benzos and other sedation together. This will be harmful. Okay, let's go quickly through these problems. See who's smart will get the answer. We'll give you 30 seconds to get the answer. So patient, we put him on EVAP, 500 tidal volume, EPAP 4, IPAP minimum 6, IPAP maximum 25, respiratory rate 12. With the maximum IPAP 25, he's getting tidal volume 400. What should you do? Increase the IPAP maximum. EVAP settings, tidal volume 500, EPAP 4, IPAP minimum 12, IPAP maximum 25, respiratory rate of 12. With IPAP 12, he's getting size 600 tidal volume. What should you do? Decrease IPAP minimum, right? So, because the machine machine will listen to you. Okay, so machine will listen to you. IPAP between that and that will never move away from that. EVAP setting, tidal volume 500, EPAP 4, IPAP minimum 6, IPAP maximum 25, respiratory rate 12. If I do 40, setting 85%, what should you do? Increase the FiO2 40% to higher. What's the other option? Increase the EPAP from 4 to 6. But in this condition, you need to IPAP, increase the IPAP minimum from 6 to 8. The machine will not allow you. So the machine is smart, right? So if you want to increase the EPAP from 4 to 6 and your IPAP minimum is 6, machine will not allow you. So you have to increase the IPAP minimum to 7 or 8 to be able to increase the EPAP to 6. Make sense? Okay. Good job up to now. Yes.
So for ABAPs, if we change the FI to, there's nothing such as the complete restoration test in the ABAP.
No.
So we don't have anyone.
No. Okay. So you can do whatever you want. Okay. One harder one. Last one. EPAP setting, tidal volume 500, EPAP 10, IPAP minimum 12, IPAP maximum 40, respiratory rate 12. With IPAP 40, he's getting tidal volume 400 and 40% FI2 and SAT is 100% and CO2 is still high.
Decrease saturation target.
The machine, there is no more than that.
Decrease saturation targets 100% should decrease to 92% so that why is
But this is not your problem. Your problem is your CO2 is high. So that
Is he leaking?
he's not leaking. Good thought.
increase.
Increase the rate. He's already breathing 25.
Can we,
His CO2 is good.
can we
but
decrease
he's
the
acute.
difference between IPAP and EPAP? Decrease-
Like what?
Like increase
Getting
the
close.
EPAP,
Increase the IPAP minimum.
increase the EPAP, increase the EPAP.
Increase.
Decrease.
Decrease the EPAP. So I may go to EPAP. This patient is not hypoxemic, right? I don't need the EPAP of, even if he's sleep apnea, I may try to do that. The problem now is hypercarbia. EPAP of 10, I reduce it to 4 and reduce the IPAP minimum to 5. Now I increase the pressure support to 35 instead of 30. Make sense? Got it? No? You didn't get it? So I cannot go, so what wash your carbon dioxide or what give you the larger tidal volume is the difference between the IPAP minimum and the IPAP maximum. I'm not able to increase the IPAP maximum. So what I will do, I will decrease the IPAP minimum. To decrease the IPAP minimum, I have to decrease the EPAP to be at least 1 below that IPAP minimum. So I'll go down with the IPAP minimum to 5 and the EPAP to 4. Now this will give me, instead of 30 difference between the IPAP minimum and maximum, that's not giving me the tidal volume, I will have 35 difference between the IPAP. This may give you larger tidal. Make sense? Great, good job. Okay, so how long your patient came with COPD exacerbation, you put him in on the EVAPs or the BiPAP machine, proper setting. How long do you wait to decide to intubate or not? 1 to 2 hours. Don't leave him all the day and say he failed. In 1 to 2 hours, you go and clinically assess. You can get EBG, you can assess him, look at the respiratory rate, look how distressed your patient is and see how he is. So both clinical and EBG will help you to decide. 1/3 of your patients will fail the non-invasive positive pressure ventilation and will need intubation. These are some criteria. So worsen clinical condition, mental status, tachycardia, tachypnea, hypoxemia, worsen EBG or no improvement in your EBG. All these are criteria. To wean the EVAPs, again, patient is ready. This means your problem that you put him on the EVAPs 100% of the time is getting better. CO2 is getting better, mental status is getting better, he is less distressed. There are 2 ways to wean. You can wean the setting or you can wean the duration. There is no clear weaning guidelines. But if your patient is ready, this is what I do. I, instead of 100% time on the EVAPs machine, I still use it 100% of the time at night, and during the day, 2 hours on, 2 hours off. And if he can't tolerate 2 hours off the machine, I let him. Okay. Remember, if you keep him MPO, be sure you have some D5 in the vein so he wouldn't get hypoglycemia. Okay. hypoglycemia in the ICU is worse than hyperglycemia. What's goal blood sugar in ICU? Board question? 140 to 180, right? So that's how many board questions you mentioned? Okay, so if he's tolerating 2 hours on, 2 hours off, doing well, I go 4 hours on, 4 hours off. Then I go to full night on and no EVAPs during the day. This is what I personally do. You may be different from person to person, but I like to wean the time gradually. Then if your patient has chronic hypercardia, you need to see if he qualifies for home BiPAP machine or EVAPs machine. Patient position, again, never restrain your patient when he is on any type of non-invasive positive pressure ventilation. So you can take the mask off. Position we prefer to be 45 degrees, but you can put him flat. Even sometimes you want to put a center line. What position you need for center line? Trendelenburg. So you can keep him on the EVAPs in the Trendelenburg, but be sure his stomach is not full, so he will wrong. So your patient, you want to put him in Trendelenburg, is very orthogonal. You can put him on that CPAP or BiPAP, put him on Trendelenburg or at least flat, put the line, then put him in semicircle. Bronchoscopy, can I bronch with EVAPs? Yes, there is an adapter. I have to use the full face mask for that, and I go through the mouth. But this is high risky. The only times I bronch people on EVAPs, don't tell me PGP. I'll not bronch him on EVAPs. He's on 100% oxygen. Only time I bronch people on the EVAPs if they have atelectasis and it's causing the hypoxemia and I want to clean this mucus plug. Okay, but I can bronch. Sedation, I prefer to avoid too much sedation. Presidex is used, but don't slow them down. So just be sure your patient is responsive, can protect airway if he vomits or something like that. And again, never restrict. No feeding if they are on continuous. No NG tube or OG tube or the puff if the patient is on continuous. Use D5. You can use D5 up to 7 days with no problem before you need TPN. If you need TPN, use TPN. Nebulizer versus inhalers, no difference. But if you use inhalers, you don't give 2 puffs. We give 4 to 8 puffs every time because a lot of that will be lost in the tube. Same thing on ventilator. Travel, he wants to go to Hawaii. This is not what we mean by travel. Travel, you want to send him for CT. You want to send him for something. If it's not really emergent, you cannot send the patient to CT on BiPAP. You have to use ventilator. It may not give you the same portable ventilator setting. So if it's not really urgent thing, don't send him. But if you really want to get CTA to rule out PE, just send him on the ventilator quickly and let him come back. Where to manage him? Anybody who needs continuous non-invasive pressure should be in at least PCU or ICU. Don't put him continuously on the floor. Minimum to use it to send him to PCU. You need to consult pump. The patient needs continuous. If your patient is naive and you started non-invasive, you need to consult pump. This is a COPD patient for the sake of the time, severe COPD, and he came to the ED with 80% sat on room air. They put him on non-rebreather mask. We talked about that last 2 days, right? And his sat is 100%, ABG, CO2 is 185, then he gets into it. Okay? So be careful. COPD, so gold sat is 88 to 92. Would he benefit from non-invasive post-pressure ventilation? COPD exacerbation in the hospital? What's the thing that improves mortality and COPD exacerbation in the hospital? Steroids. What's the lecture? Non-invasive post-pressure ventilation. So don't forget the lecture. If I'm giving you a lecture, I will ask you about the lecture, right? So this is not a steroid lecture. Right? So non-invasive, how does it prevent intubation? And when they get COPD patients get intubated, they get bad and they complicate, they die. So non-invasive post-pressure ventilation BiPAP or EVAPs prevents intubation, improves mortality in the hospital. What improves mortality of COPD patients outside the hospital? Oxygen, if they qualify for oxygen. You need to know this slide from up to date about the oxygen. With no comorbidities, with one of the 3 comorbidities, different values. You will have that a lot in the board. Okay, so the three comorbidities: hematocrit above 55, T pulmonaire, right heart failure. These are the three comorbidities that will change your required setting from 88% and 55 in the ABG to the 9s, 89 SAT and 59 in the ABG. So 88, 55. If you don't have any of these, if you have any of these, it will be 89 and 59. Make sense? Great. So what mode and what settings? You can use BiPAP, but be sure you control the tidal volume before you leave him, or you can use EVAPs. Would you correct this patient to 40? This patient is acute and chronic. If you calculate, you remember when you calculated the acute and chronic? Okay. So this is important. You don't wash him to 40, because washing him to 40, if he refused to use the machine, or you cannot qualify him to use the machine at home, your bicarb is 36, will go down to 24, then he will retain carbon dioxide, go back to his baseline, then he will become acidotic and you intubate him. What does the GOLD criteria? Everybody's familiar with the GOLD, right? GOLD. Anybody's familiar with GINA? So GINA for the asthma. I don't know if GINA 22 came or not, because 2 weeks ago I looked. I found usually it comes in February or so, but in March it wasn't there.
December 2021.
The last one,
There was a December 2021.
GINA. Okay. So the GOLD 2022 and all the GOLD before, they tell you when to use non-invasive post-pressure ventilation for COPD patients. pH 735 or less, and CO2 45. You don't have to wait until your patient is 100 carbon dioxide to put him on non-invasive. Patient comes with COPD exacerbation. You get an ABG. His pH is 735 and CO2 is 45. He qualifies for non-invasive post-pressure ventilation. This is when you need to start it.
Even chronic patients, right?
Yes, because chronic patients should use something, right? He's not using something at home, but this is during the exacerbation. Other indication is tachypnic, hypoxemic, but for the hypercarbia, 45. So 45 and pH 735. Patient with heart failure, would they benefit from non-invasive? So these are the strongest: COPD exacerbation with hypercarbia, but not COPD patient with hypoxemia without hypercarbia, and acute pulmonary edema. These are the most likely to benefit from your non-invasive post-pressure ventilation. CPAP versus BiPAP. So both have tons of studies. I will not go through them, but tons of studies for CPAP, tons of studies for BiPAP. Even there are studies compare CPAP to BiPAP. Both are equal. If your patient has hypoxemic respiratory failure, if your patient has hypercarbic and hypoxemic respiratory, use BiPAP or EVAPs. So hypoxemia only, CPAP or BiPAP or EVAPs. Hypoxemia and hypercarbia, BiPAP. And how does it work? Decrease preload, decrease afterload, and prevent alveolar collapse. So which heart failure patient may worsen with non-invasive post-pressure ventilation? What? Right? Preload dependent heart failure, because CPAP will reduce your preload. Make sense? Can you use CPAP and MI? Yes. There was some rumor that CPAP may increase the risk for MI. That's not true. Patient comes with chest pain, you think he needs CPAP, use CPAP. So pulmonary edema, these are the studies. I will not go through all of them, but these are tons of studies for pulmonary edema shows benefit. CPAP versus BiPAP, no differences. The gray means no differences. So hypoxemic respiratory failure, a lot of benefit, decreased intubation, decreased mortality, meta-analysis of many studies, a lot of benefits. Who are the less likely to benefit? Asthma exacerbations, very small studies in the ED. I don't remember how much they compared, I think 15 to 15. Very small study showed significant decrease in admission for asthma exacerbation, but did not change the outcome in the hospital. If they needed admission, did not. But If the patient is dyspneic, you can try to use that instead of intubating. So you can use some CPAP or BiPAP. So acute hypoxemic non-hypercardic COPD will benefit less. So the benefit is not as good as the hypercardic. Asthma exacerbation, these are the studies. Decrease hospitalization, but no benefit in the intubation rate and the admission, most of the studies. So a lot of controversy. This study did not reduce intubation rate, and also hospital stay did not change. But this small study that was done in the ED reduced admission to the hospital. Pneumonia, controversial too. Can use it or not. Pneumonia may have a copious secretion. They may not need something to prevent them from coughing the secretion. Never put scopolamine patches on patients with pneumonia. I will stop those. I usually tell you when I'm on consult, I want to do that. You are okay? I will do it. Most likely you will say okay because you consulted me too for that reason. So you will take my recommendation. But there are a few things I stopped without telling you. And one time I stopped it and they were using the scopolamine patch for nausea. So, but patient had pneumonia. I don't want to decrease and dry the secretion. I want him to get the secretion out a cappella. So best if your patient has CF or bronchiectasis or something like Metaneb machine. Everybody saw this blue small machine. Metaneb can be used on patient who's awake, patient on ventilator, patient on non-invasive. Can use it. Can use every patient. Metaneb, this machine that checks the chest, make them cough them out. Immunocompromised patient with HIV, PGP, there was some data that there may be some benefit, but also controversial. ARDS, controversial, usually ARDS, but which are the common cases of ARDS we had in the last 2 years? COVID patient with ARDS. So this prevented intubation. We had somewhat better outcome if we avoid intubation. So we used for ARDS from COVID, and this worked reasonably in many patients, prevented intubation. Post-extubation, the 2 people or the 3 people that will benefit from extubation immediately to non-invasive. Don't wait until they worsen and put them on non-invasive. Immediate COPD exacerbation, pulmonary edema, people with obesity, hypoventilation syndrome, or neurovascular disease. Okay, so don't wait till 9 p.m. You extubated at noon, 9 p.m. He's worsening, you put him on non-invasive. Worse, intubate, worse outcomes. But if you extubate immediately for 2 to 3 patients with pulmonary edema, and I had a patient last month was on the cardiology service and intubated, and he did wonderful on 5/5 of the trial. Oxygen was 160 something. Once he was extubated, we put him on the CPAP machine for 3 hours. Did okay, then started to deteriorate. They need this speed. Pulmonary edema, they need this speed. Same thing for COPD exacerbation. Same thing for people with hypoventilation, obesity, hypoventilation, or neuromuscular disease. You can use also, you want to intubate a person, you can put him on the CPAP or BiPAP to pre-oxygenate him before intubation. Works better than oxygen, better than bagging. Okay, so if the patient is awake, you are doing somewhat elective intubation, just put him on the non-invasive for 10 minutes or so, oxygenate him well, 100% oxygen with the machine, better than bagging him. So this may reduce your time for sedation. Once your oxygenation is good, you can start preparing him to get intubated. Neuromuscular disease, everybody's familiar with the 20-30-40 rule? 20-30-40? Right? So, okay. So 20 is 20, not count. It's 20 ml per kg vital capacity, 30 NEF minus 30, and positive expiratory pressure 40. I think we are out of that. Okay, so improve survival in patients with neuromuscular disease and ALS. Any questions?
I have a question.
Sure.
I was running feedback before. I got sometimes the machine doesn't have the instructions saying just the pressure support. How much will be the pressure support?
So you want to put them on 8/4?
Yeah.
Your pressure support will be 4.
So I would choose
Pressure
four
support is
over four.
IPAP minus EPAP.
I would choose 4/4.
For pressure support, this is mainly ventilators. You're talking about ventilators, not the D6. Okay, great. So now let's distribute these questions. If we can. Everyone should get one. The last page is course evaluation. Please fill that because this is how we modify our course every year. So we didn't start like this. We started better. So we modify things based on what you ask us to. It's just anybody doing that? Too much? Okay. Yes, very much.
Do we get a bubble sheet with that or?
No, just answer that. And I will take it from you this time. You can get that. I will not tell you about that. Question about the